At the policing board, the oral briefing from the PSNI and adult protection's coming later on, because I know they have a lot of business and that'll affect some of our members who are there. So with that, we will declare the meeting open to the public. As always, committee meeting is going to be recorded and it will also be broadcast throughout Parliament buildings and also online. Apologies? None? Okay, as I say, there's a few who are at the policing board who've contacted to say they'll be late.
Chair, well, I left. It wasn't even 2/3 of the way through whenever I left after 1 o'clock. It still there was, and I hadn't had lunch and stuff. So I'd say it's going to go on to about 4 o'clock today.
Okay, so we might not see them.
You might not see them.
Okay, can't do anything about that. Chair's business. I have a couple of things just I want to mention. So today, the 11th of December, is organ donation discussion day here in the north. So I think it's important that, from the Health Committee's point of view, that we mention that. It's obviously an important day to help raise awareness about organ donation, the importance of that. So for everybody listening, I would encourage people to give it some thought if they haven't already done so. Discuss with family and loved ones, and I would encourage people to record the decision on the NHS organ donation register. We all are aware of the need for organ donation. It does help save lives and improve lives, and is very, very important. So on this day, I think that's an important message from the Health Committee. Second thing, members, I had a contact at my constituency office about a constituent who receives chemotherapy at Laurel House. So chemotherapies seemingly happen every Thursday, but because Christmas and New Year both occur on a Thursday, this particular constituent was initially told that they don't do it on bank holidays, or they certainly weren't going to do it on Christmas and New Year's Day. So she would actually have had missed her treatment for 3 weeks. It was to be her last treatment on the 18th, and because of the closures, it was then going to be the 8th of January. So literally 10 minutes in advance of this meeting, my office contacted me to say that she has been offered a couple of days, but I want to raise it in the hope that we can contact the Minister just to get an assessment if this is common practice for patients who receive chemotherapy to miss it on if a bank holiday occurs on a Thursday, as it is in this particular case, and to ask if, it would make sense to me that alternative dates be sought. I mean, somebody receiving this kind of important treatment can't really afford to be waiting an extra 2 weeks over what they should be. So can I get the committee's acquiescence to contact the department just in relation to that query?
Chair, it is an issue that I have come across before, and I think it doesn't matter where you're receiving the chemotherapy, that there is an issue. So it is actually worthwhile getting clarity, because if it's you and you need your treatment, it's an extremely important thing. Absolutely. We'll write to the department asking about what happens normally in the case of bank holidays, but with the caveat that we would like people to be getting their treatment as quickly as possible, and alternative arrangements if it does fall on a bank holiday. Okay, draft minutes. Can I refer members to the draft minutes of the meeting held on 4th of November, page 5 of the main pack? Everybody content? Okay. Matters arising. Just can I refer members to a revised DALO readout at tab 4.2 of our table papers on the outstanding responses. So, you'll be aware at every meeting that issues come up. We write to the department, we ask for issues to be brought to our attention or information to be brought. So the committee staff have requested a full update on each of these outstanding issues on the tab. Also on our table papers is a response from the Minister in relation to queries that I had raised in relation to the real living wage for social care workers. So in the response, the Minister apologises to us as the committee for providing us with the incorrect information, and states that the 70% figure stated related to advertised role, which was approximately 50 jobs. However, some of these roles included additional duties and senior advanced caring roles. Minister also outlines that he has met with the independent sector, and a number of actions are being taken forward to the department. We also wrote in the first instance after the committee, but we also wrote further to that, seeking additional response, and we're still awaiting from the Minister
on that issue. Everybody content?
Chair.
Yep.
Can I just say, it does sound a bit weak that the Minister gets his figures from such methods. I think the committee was quite, I suppose, I was disappointed, certainly. I was quite shocked when I read that. So I think, is there anything that we should do to write back and maybe suggest that more robust figures and a method for deriving those are used by the department rather than the one that was described?
Yeah, I mean, I agree. When I read that, it looked a bit amateurish that he was quoting to us in the Health Committee, and I think he may well have quoted it in the Assembly as well, from a perspective of 50 jobs advertised that clearly could have been raised the level of pay that I think what we maybe could do as well on top of that is write to the independent sector just to see if they have any updated response, because they did write to us as well in the aftermath of their meeting. Okay, so moving on. Yes, go ahead.
As an add-on to that, sorry. I mean, there's some talk on news bulletins today with the unions and so on. And it would be useful also to, if the committee could agree to write to the Minister urging him to take as early action as he can to make sure that this issue of the real living wage is resolved. Just to put it on the record as a view and so on, I think is quite important.
I think that's important. We do have another briefing on the budget in January from the Minister, so some of these issues will no doubt be discussed by us then, but we definitely should write urging from the committee that the Minister takes important action on the living wage. Okay, moving on. Oral briefing on community pharmacy. So can I refer members to tab 5 of our main pack, page 23, and also table papers, page 11 and 18, is where our information is. And can I welcome Professor Cathy Harrison, Chief Pharmaceutical Officer within the department, Ms. Cathryn Turner, Interim Head of Pharmacy and Medicines Management, and Ms. Teresa Magirr, who's the Co-Director of Specialist Services within the department. So you're all very welcome. It's good to see you. I'm going to hand over to yourselves just for some brief introductory remarks, and then we'll take questions as normal.
Thanks very much, and good afternoon, Chair and committee members, and thank you for the invite to attend today. The committee was provided with a briefing paper in advance of the meeting, and also following a subsequent request, we provided you with an update, with an updated paper to address additional questions. I'm Cathy Harrison. I'm the Chief Pharmaceutical Officer at the Department of Health, and I advise on medicines and pharmaceutical matters, and I provide the professional and strategic leadership for the pharmacy profession in Northern Ireland. And this includes responsibility for development of the community pharmacy strategic plan and the strategic aspects of its implementation relating to legislation, workforce development and e-pharmacy. I'm joined by Cathryn Turner, who's Head of Pharmacy and Medicines Management at the Strategic Plan and Performance Group. And as part of the department, SPPG's Pharmacy and Medicines Management team is responsible for the planning and commissioning of pharmaceutical services across Northern Ireland, and for translating the vision of the strategic plan into safe, cost-effective pharmacy services. And this includes managing the associated funding and the Northern Ireland drug tariff to ensure cost-efficient prescribing. And I work closely with Kathryn, and our teams also work collaboratively together on these areas. And I'm also joined by Teresa Magirr, who is Assistant Director for Commissioning in Hospital Care Directorate at SPPG. The first thing I would like to say is I'd like to begin by offering an apology to the committee in relation to an error in the reported figure for community pharmacy funding in relation to Scotland that I provided at the March meeting. And following this meeting, the annual review of commissioned pharmacy services for the 23-24 report was withdrawn and was corrected and republished. I must assure the committee that comparisons with other countries are not used to inform decisions on community pharmacy investment in Northern Ireland. And further to that, SPPG have now revisited their analysis of the Scottish model of funding, and Kathryn's going to provide more information on that in her update. The topics that Kathryn will cover a number of topics on funding and commissioning, and then I will come back in with a short update on some of the strategic developments since we last met. I'm going to now pass over to Kathryn.
Thank you, Cathy.
Good afternoon. So firstly, I would like to fully acknowledge the absolutely vital role that community pharmacy plays both now and in our future vision for healthcare services in Northern Ireland. In the very challenging health and social care environment, we're absolutely committed to working with Community Pharmacy Northern Ireland, CPNI, to deliver fair, sustainable and affordable funding for community pharmacy. So as Cathy has said, I'll provide an update on SPPG commissioning, focusing on community pharmacy funding and the commissioning of services. So the department has made significant investments to support community pharmacy, and funding has increased steadily over the last 7 years. For the current 25-26 financial year, the opening position increased by 11.7 million or 8%, bringing it to a total of 158.7 million. This is 52.6% higher than the opening position in 2018-19, and I'll provide some of the elements that make up that funding increase shortly. In addition, Minister recently confirmed that funding for HSC pay awards for 25-26 has been secured. This is anticipated to add a further 4.7 million, bringing the total recurrent funding to 163.4 million. In order to understand how community pharmacy funding works, it's important to consider the Northern Ireland drug tariff, which sets out the remuneration and reimbursement that community pharmacy can expect from HSC, including the reimbursement rates for medicines that they dispense. So the prices of medicines fluctuates daily, and with over 45 million items dispensed on average each year, it's simply not practical or possible to reimburse pharmacies with the exact amount that they paid to purchase an individual item. That means at individual prescription level, pharmacies may sometimes receive less than they paid for the product, and at other times they may receive more than they paid for the product. And an annual margin survey is completed to ensure that on average the reimbursement arrangements for community pharmacy cover the cost of purchasing the medicines plus a guaranteed level of margin or retained purchase profit, meaning that HSC dispensing should be a profitable activity overall. Following on from the presentation at Health Committee in March, I sent the committee the margin survey methodology, and in 24-25 the profit margin was set at a minimum threshold of 31.5 million. That was an increase of 5 million from the previous year, and then for 26-27 we've increased it further to 34 million, and that's the minimum threshold. It should be noted that the actual annual margin achieved by community pharmacies in Northern Ireland has significantly exceeded the minimum threshold over the last number of years. And importantly, unlike other UK regions, any excess in margin is not recouped, meaning additional income for pharmacy contractors above the agreed financial envelope. In conjunction with margin modulation, discount clawback, sometimes called discount deduction, is a mechanism where HSC reduces the amount it reimburses pharmacies for prescriptions based on the assumption that pharmacies receive discounts from their wholesalers. Its aim is to control or manage the profit that pharmacies make on HSC-funded medicines. Following a consultation, revised discount arrangements were introduced from January 24. These arrangements aim to ensure that clawback is more appropriately applied to pharmacy contractors. The transition completed in April of this year, and during the 15-month transition period, approximately £1.7 million less was clawed back from discount compared to the old system. And upon completion of the transition in April this year, the discount applied to appliances, and appliances are things like stoma products, they're not medicines, they're stoma type preparations, that changed from 10.39% to 0. So what that means is that for appliance items, they are reimbursed without any deduction being applied. And the end result of that will be approximately £2.8 million per annum, which will be retained by the community pharmacy network, which was part of the funding increase for this year. That was recognised in that funding increase. The funding structures in Northern Ireland and Scotland are significantly different, And as highlighted when we were last at Health Committee, it isn't possible to map across the funding invested at a service level from the Scotland to Northern Ireland, given the differences in how funding has been allocated and described within each of the contractual frameworks, and how funding is allocated linked to services. However, these differences continue to be raised, particularly the fact that Scotland currently does not apply any discount clawback. Therefore, we have undertaken, from the summer onwards, we've undertaken further work with Scottish Government to gain a greater understanding of Scottish funding arrangements. And from this, we've been able to conclude that whilst recurrent core funding levels are broadly comparable, they're made up very differently. And we now understand that Scotland's suspension of generic discount clawback was feasible due to legacy differences between the Scottish and the English drug tariffs. And this will change. We've been informed by Scottish colleagues that this will change in the near future as tariff prices begin to align. We in Northern Ireland will continue to monitor, will continue to work with CPNI and monitor the Northern Ireland drug tariff. We've established fora and a relationship with CPNI to monitor the impact of the tariff and to consider further developments to the Northern Ireland drug tariff. Community pharmacies provide a range of highly valued commissioned services, and in the last commissioning period we introduced a Pharmacy First service. It was developed to enable people to seek advice and treatment for a range of conditions without the need to see a GP. The service has expanded from everyday conditions such as minor skin infections to emergency hormonal contraception and urinary tract infections. The Pharmacy First sore throat service is now available in over 400 pharmacies, and it offers a high-quality clinical pathway for those aged 5 years and over. Using point-of-care testing, the service supports the appropriate use of antimicrobials and more fully uses the skills of pharmacists to deliver accessible clinical care. Over 16,000 people access the service between December 24 and September 25, with only 21% receiving antibiotics, and that demonstrates excellent antimicrobial stewardship. Evaluations have shown that these types of community pharmacy services displace activity from other service providers, increasing capacity within the HSC. For example, since the introduction in 2022 of the emergency hormonal contraceptive service, there's been an overall reduction of 78% in the number of prescriptions for EHC, emergency hormonal contraception, issued by GP practices, and a reduction of 98% in prescribing by out-of-hours services. Other services provided by community pharmacy include the community pharmacy vaccination service, which is now integral to the delivery of vaccinations across Northern Ireland. And as of yesterday, that service had delivered 44,000 flu vaccines, and a lot of those to care home residents and staff. A new 3-year commissioning plan for 2025 to 28 has been developed in partnership with CPNI. These new commissioning arrangements will progress the department's strategic vision for community pharmacy, expanding clinical services such as Pharmacy First, better utilising the skills of pharmacy teams, and offering safe, convenient access to care. It's through this commissioning that additional funding can be bid for to deliver new services. In the coming weeks, Minister will be launching an enhanced community pharmacy palliative care network as a key output of the Winter Preparedness Plan, which will ensure timely access to palliative medicines and expand the advice and support for patients and their families. We note the publication of the Health Committee report on access to palliative care services and will consider those recommendations relevant to pharmacy that have been made to identify further improvements in care for patients at end of life. Full delivery of the strategic vision is subject to additional funding and an IT infrastructure to support the provision of enhanced services within community pharmacy. The vast majority of these services rely on manual paper records, and development of pharmacy IT systems is a priority. The e-pharmacy digital reform programme for community pharmacy is critical to the transformation and transition from manual paper records to electronic. and Cathy will provide a further update on e-pharmacy. And I'll pass you back to Cathy. Thank you.
Just a few more minutes of the update. Thank you very much. So the department has produced an annual report review of commissioned community pharmacy services for 2024-25, and that's currently with our press office for publication in the coming weeks. But I can advise from that report review that the department is assured that the review has concluded that in Northern Ireland the delivery of community pharmacy services is in line with the commissioning plan and in terms of our core, additional and local services. So we have received, the review is providing us with assurance of that and within the funding available. The report also shows that Northern Ireland is well provided for in respect of access to community pharmacies. It had 508 community pharmacies at the 31st of March in 2025. That was 3 fewer than the same date the previous year. And I can report that actually, just for interest, for this year we've had no closures to date. So that number has remained steady. The review also shows that there's good access to community pharmacies across Northern Ireland, with over 99% of people living within 5 miles of a community pharmacy. And it's worth acknowledging that in rural areas, that the pharmacies can be the most readily available source of primary care support and advice. And community pharmacies work very closely with our general practices and support access to prescribed medicines, dispensing over 45 million prescription items in that year and providing advice on medicines, health and wellbeing, as well as the services Kathryn has mentioned. A short update just on some of the elements of the strategic plan that fall to my department and my team. In terms of legislation, we have recently formed a new community pharmacy legislative reform programme team, and that's working with CPNI, and that's been established to take forward a comprehensive programme of work. And the legislative reforms there are going to be aimed at really looking at modernising the systems for safe and reliable supply of medicines and professional advice from community pharmacies, in line with the legislative reform detailed in the community pharmacy strategic plan. And in those we're looking at our pharmaceutical regulations. Legislative changes will support the underlying clinical governance arrangements, which are becoming increasingly important given the wider range of services and clinical responsibility that community pharmacies will have. And also, during this time, we have also introduced legislation. In addition, we will also look in those pharmaceutical regulations to bring in changes that will allow the electronic transfer of prescriptions, and also take forward other changes if needed in relation to original pack dispensing. And we will also intend very soon, we have also introduced changes at a UK-wide level in relation to supervision of medicine supply within community pharmacies, and we are considering changes to legislation in relation to the regulation of pharmacy technicians in Northern Ireland. In relation to workforce, we have funded a major programme of work which involves funding the Northern Ireland Centre for Pharmacy Learning and Development to support the development of the entire Northern Ireland pharmacy workforce, and workforce developments this year that support the community pharmacy strategic plan include completion of the implementation of mandatory UK-wide reforms to the initial education and training of pharmacists that now provides all of our pharmacy students in university up to 10 weeks clinical training in multi-sector training sites. And also the introduction of a new model embedding independent prescribing training into the foundation training year, so that pharmacists are annotated as independent prescribers from their first year on the professional register, and the first cohort of those students are undertaking their training now. I'm pleased to report that we have around 197 community pharmacies supporting the experiential learning programme for undergraduates, and 200 community pharmacies are now offering foundation training year, and that's our highest number ever. Just 2 final very quick updates. In terms of the e-pharmacy programme, the e-pharmacy programme is a very important component of the community pharmacy strategic plan, and it's recognised that e-pharmacy systems will transform how community pharmacy services are delivered in Northern Ireland and really facilitate the service growth that we want to see. The scale of opportunity is really significant when you think about 45 million prescription items that are prescribed and dispensed annually, and all of the handling that goes on with those in paper form. and also that we have around 123,000 people visiting community pharmacies each day, and that all of our Pharmacy First services and other services are also paper-based at the moment. It's acknowledged that electronic transfer of prescriptions is essential for transforming prescribing in general practice as well, and you'll have noticed that it was included in the recent PAC report. And the department, following the last meeting that we met with you, the department has submitted a comprehensive bid for public sector transformation funding to cover the introduction of electronic transfer of prescriptions. And we await confirmation of that outcome. And also that bid also included a proposal to digitise the clinical service delivery within community pharmacies, so it will really move forward community pharmacy services. And if funded, that programme will rapidly accelerate the reform that we want to see in community pharmacy. And we would anticipate that we would have the introduction, if funded, by the end of this decade. So that would really rapidly accelerate our plans. I was here a couple of weeks ago talking to you about the neighbourhood model. I did want to just mention that community pharmacy has an important role in that. If you want to ask anything about that, I'd be happy to answer it. But that is the end of our update. I hope you found that helpful, and we're happy to answer any questions that you may have.
Okay, thank you very much. That was useful. In terms of the e-pharmacy bid, I mean, this committee have put ourselves on record as thinking that would be extremely valuable and supportive. Do we know how much the bid is for, and is it a bid for the rollout across the whole of the north or just parts?
Bid was for £43 million. It was for 2 transformational projects for the electronic transfer of prescriptions across all of Northern Ireland, and for the introduction of what we call a Go Pharmacy NI digital system to fully digitise community pharmacy services as well, and link them up with general practice records and link them up with the wider system.
And when will we know about the success or otherwise of the bid?
We understand the latest I have on this, actually, because the most up-to-date position on this is we understand that the Transformation Board has recently made its recommendations to the board to the Finance Minister, and that these are currently being considered, so we're hoping to hear quite soon. Okay, well that would be good news if it was in the affirmative. A couple of points in terms of your update, because Kathryn, when you were reading, or when you were talking, you mentioned a different figure than I had with regard to the sore throat scheme. So I'm reading 8,700 from December 24 to March 25. I think you gave a different figure for a different period.
Mine was from December 24 to September. Okay, 25.
Fair enough. So I'm interested in that because we do obviously support shift left, and we want to see as much happening locally in primary care, so pharmacies are very important in that, and there's some good statistics there about people using the services. Do we know though how many of, whether it's my 8,700 or your 16,000 who go to the pharmacy for that scheme, how many of them subsequently still go to the GP, or is that 16,000 that were taken out of going to GP?
We don't know in relation to the sore throat service as yet, but that was, if you remember the figures that I gave you for the emergency hormonal contraceptive service, which has been in place longer. That service, we have measured that displacement, and we know that it's 78% of the prescriptions for EHC that would have been in general practice are now in community pharmacy because of having the EHC service in place, and 98% of the scripts that would have been dispensed in hour to hours for EHC are now being prescribed are now being prescribed and dispensed in community pharmacy.
So at some point we will be able to say
we will.
That there are 16,000 who went to the pharmacy for a sore throat, and 2,000 of them subsequently went to a GP, or none of them went to a GP.
I mean, I'll be honest, it's difficult in a manual record environment. It will be much easier when we have the Go Pharmacy NI that Cathy talks about, because we will obviously have then electronically, we will know, and we will have that link between the pharmacy and the general practice. We're doing it through sort of manual evaluation and extrapolation currently.
Okay, and then my next figure, so there was 87,000 went to their pharmacy, autumn 24 to 25. and all it's saying is this year that it's going well, the vaccination scheme with pharmacy. Do we know is going well mean it's ahead of last year or behind?
I had a feedback from a community pharmacist on Friday that on Friday they administered more flu vaccines in one day than they had administered in the entirety of the programme last year.
Okay, well, that is good news.
Yeah.
See, in terms of some of these things, I mean, we're in the health committee, so we know regularly, because we hear regularly, the services that you can get in your local pharmacy, and people who are regularly attending GP will know that. Do we need to publicise better exactly the services that, I mean, because local pharmacies can do an awful lot there, as we've heard, but I'm just not sure that the general public know the extent of what pharmacists can do, and in some cases are going to the GPs. How can we publicise better the work of pharmacies?
Yeah, and I think you're absolutely. I mean, we use NI Direct, we use social media, but I think we can do more. I think definitely it's something that we absolutely, and it will be built into part of Go Pharmacy NI. Will be a directory of services that community pharmacy can provide. But we need to do a lot of work before that, because we need to continue to ensure through all of the channels open to us and using all of the available methods that we have to get the services publicised. And we do. I mean, we're just about to launch a palliative care, the palliative care obviously network, so we're in the process of writing to GPs, writing to Trust, writing to out of hours to make sure that everybody knows, but it's then continuing after the service has been launched and ensuring that we keep having that repeated message out there, and that's probably something we need to focus on. Okay,
so all that brings me to funding. So we obviously met you back whenever it was 6 or 8 months ago. And the main focus of that conversation, because we had CPNA and afterwards, and before you, so it was funding. I mean, I have had a few community pharmacists contact me in the run up to this meeting. I've spoken to a number, and I mean, they're still telling me that the issues are the same as they were. So I mean, we've had a briefing in relation to funding, how it compares. We've had a briefing in terms of the clawback. I mean, it sometimes feels a bit complicated with regard to what we're getting. I mean, and I do understand it, but what I don't understand as well is that, you know, the department are saying one thing, but community pharmacists are telling me another thing, and are equally vociferous, particularly around core funding and the clawback issue. So, I mean, they're telling me in a lot of cases they're dispensing drugs at a loss because of the clawback issue. There's an added issue at the minute, it seems to be in the north, with regard to, you know, a reduction in wholesalers. So there isn't the same level, there's a reduced level of competition within wholesalers. So that in some cases is impacting community pharmacists. They're telling me that sometimes maybe potentially they could get a cheaper drug, but they have to wait 6 days, which is of no benefit, and sometimes wholesalers are you know, can basically charge what they want because of the reduction and the fact that they have community pharmacies over. So the issue of core funding hasn't gone away, the issue of the clawback hasn't gone away, and from what I can see in my engagement with community pharmacists, they are still as adamant as they were that this is an issue needs resolved. I mean, in your briefing, you're saying that you've had good conversations with community pharmacy and I about commissioning of services and all that's going. I mean, my appeal today would be that I still think there is a need for the department to re-engage with CPNA around the issue of clawback and of the issue of core funding, because I don't want a similar issue developing as we have seen with the BMA and GPs. Because Cathy, you talked about the importance of our neighbourhood, and that's important. I'm going to ask a question on that. But we need pharmacies to be key players in this. Some of them have said to me, there was a discussion last week, the neighbourhood model appeals to local pharmacists, but they're not going to be doing extra work for less money. So my appeal is, will the department re-engage with CPNA in terms of a serious conversation about core funding and clawback?
We have established a range of fora where we do engage with CPNA, and we have a drug tariff liaison group, which is the group in which we do engage with CPNI. And as I said earlier, we will continue to discuss the Northern Ireland tariff, and this year we have reduced the clawback on appliances in recognition of some of the difficulties that contractors faced.
And will the Minister involve himself in that conversation? Because I mean, this is an important issue that I mean, certainly I believe the Minister needs to be taking some kind of lead on.
The Minister wasn't involved in those discussions because it's a very productive forum, to be honest with you. I mean, it doesn't mean we agree on everything all the time, but there really is progress being made where we can, and I think that's demonstrated, with what Kathryn has said in some of those areas of discount. Look, conversations are always open. Honestly, we are not saying that we are not open to considering options in relation to funding moving into the future. But we have a very clear. We benefit with community pharmacy that we have a very clear strategic vision. We have an agreed commissioning plan for the next 3 years, for example, so we know where we would like to invest more money if we can. We know therefore how they'll fit in with wider strategic developments.
And that was very much an agreed plan. That was work that we undertook a review of the last commissioning period, and that is published, and you can see the range of services that we delivered, and I described some of those to you. We now have a very clear 3-year plan agreed between ourselves and CPNI through a series of meetings, and we have that now published, and that is the plan that we will work to deliver the types of services that the public need and that we've raised today.
I mean, CPNA in conversation with me don't dispute that there are lots of good things ongoing, and engagements are taking place. But I mean, I suppose it's slightly different to say ongoing conversations are happening, or we will certainly engage in ongoing conversations. That's slightly different to saying we will engage on those two specific issues, because I mean, I'm told by CPNI and community pharmacists that they aren't content with regard to core funding and the clawback issue. So I mean, essentially what I'm looking for is some kind of commitment from the department that they will engage on those two issues.
We certainly will engage with them in relation to the drug tariff, for which, as I've said, discount clawback is part of the drug tariff mechanisms. And this year we did remove that clawback on appliances. So we have listened and actioned where there is evidence to do so. The margin survey is really key here. And the margin survey is the survey that determines how much profit there is on the purchasing of medicines. And as I said earlier, and it's in your briefing pack, the margin has exceeded the delivery over the last number of years. And in Northern Ireland, we do not, when there is excess margin delivered, we don't take that excess margin back. They do in other parts of the UK. We don't. That stays in the community pharmacy economy.
Last question from me. You give a commitment there about engaging with us or on our recommendations within the palliative care report, so that's very welcome.
Absolutely.
I also had a conversation with a pharmacist, and he was saying, even with regard to the winter we're currently in, that he believes he could do more in terms of social care and helping to get patients out of hospitals. The local pharmacists can do care packs and administer drugs that maybe carers can't do, but again, this is an additional service. But I mean, certainly he believes that they could be helping to get people out of hospital if that was a service that was commissioned within local pharmacy. And I'm just wondering, in terms of the department's winter plan, could local pharmacies do more than they're currently doing if they were asked to, in regard to helping out through winter pressures, particularly getting people out of hospital back home or into care homes?
Certainly all the services that we have delivered, that we commission, it's done in partnership with CPNI. So in that particular situation, I would say talk to CPNI, because we meet them every 2 weeks about service development and the services that we need to deliver, and that is the forum for taking that forward. And we certainly would welcome any opportunity of working with pharmacists to do more this winter.
Orlia?
Yes, thank you, Chair, and thanks very much, Kathryn, Cathy and Teresa. So just to go back quickly on the clawback stuff, because you'll obviously be aware that has been one of the main areas of discussion, and it was great, Cathy, just to get that that bit of clarification around how the numbers actually worked out in terms of the funding. But it is an issue that local community pharmacists keep drawing us back to time and time again, because many of them are struggling. We had a powerful lobby not so long ago. I think every single health committee member around, the issue around the wholesalers and the prices, and just that many of them were struggling. It's good to hear around the appliances that pause on the clawback. I think you mentioned 2.8 million, Kathryn,
This year.
and then some of the measures that were put in place in terms of how you work the clawback, that saved an additional 1.7 million. Is that correct?
It is.
So I do welcome that, but the message that we would be getting from community pharmacy is still in and around that overall 25 million per annum figure, and the comparison, the fact that Scotland don't pay any of that. So it's really, where does this sit? Because, it's really useful to hear your updates. And Kathryn, you had mentioned that you are committed to working with CPNA, and you had detailed some of that work that's been undertaken with the Scottish Government. And in your own words, you had says that you will continue to monitor our own tariff with CPNA and consider any further changes. So that all sounds really positive, but we're receiving a different message from local community pharmacists that's not happening, and that they're not feeling that there is any active sort of discussion or negotiation when it's coming to the clawback and when it's coming to their contracts and their core funding.
I think we've evidenced by what we did with the appliances that we are aware there is evidence, and there was evidence there that contractors struggled to get discount clawback. We did make that change within our tariff, and we, as I said, we can meet them every quarter, and we will continue to monitor the situation, and we will continue to look at developments within our tariff.
Okay, and those quarterly meetings, is that the drug tariff liaison group?
It is.
And who attends those?
Be representatives from SPPG as the commissioner, and BSO as the organisation that works on our behalf to make the actual payments, and CPNI.
Okay, and they're every quarter, and so the clawback issues then are obviously discussed actively at those.
It's a drug
those
tariff,
meetings.
and that's within the drug tariff. It's a drug tariff liaison group. It's within that remit of the tariff.
Okay, and could I ask, is there any structure or group that would sit above that in terms of how the commission and the contracts are worked out for community pharmacy?
We have a commissioning oversight group, which is currently chaired by Teresa Magirr as the interim COO of SPPG, and that meets 3 times a year. And that is representatives obviously of CPNI, SPPG and Cathy's team from Departmental Policy.
So again, there is representation from CPNI at that senior sort of management group. Okay.
We established that group about 18 months ago.
Okay. That is, well look, that's useful I think even for us to have that detail, so there is those structures in place in terms of how people can talk about and discuss these things and figure out what the best way forward is. And again, with the new 3-year commissioning plan, again, Kathryn, that you had described has been developed with CPNI. So that is an agreed plan. So was that again a sit-down agreement directly with CPNI, where obviously those funding arrangements were discussed and agreed?
We started with a workshop, and we had a workshop, and then from that we had a draft commissioning plan, and then there was obviously reviewed by each party, and then we came to a final commissioning plan, which is...
That's agreed.
Yeah, absolutely agreed, and it's on the departmental website.
Okay, no problem. That's interesting. That's good detail, I think, for us to have, because I'll certainly be feeding this back into local conversations and feedback that we've been getting from community pharmacists in our local areas. So thank you for that. And then I'd like to ask a question around the pensions for community pharmacists. So do community pharmacists qualify for a health service pension?
No, they're independent contractors.
And is that the same case then for if you're a pharmacist that works in a hospital?
They're employed by the trust.
And GP pharmacists?
Or employed by the Federation.
Okay. So that was just an issue that come up in terms of if there's a disparity around access to pensions, because they're all sort of carrying out the same, the same role and the same duty as pharmacists. So is that anything you have ever discussed with community pharmacy?
No.
No. Okay.
They're all very, because they are very independent contractors versus the
employer's responsibility.
It is, yeah.
Thank you. And then my final question is around, Cathy, you had mentioned the neighbourhood model, and I think that's what you were alluding to, Kathryn, when you had referenced what the future vision and the importance and the critical importance of community pharmacy. So at this stage, we had a conversation recently around this, and it's community pharmacy, it's GPs and it's community and voluntary are all going to be critical to making these neighbourhood schemes successful. And are you feeling at this stage that there has been a good level of engagement with community pharmacy and that they're actively buying into this new project?
Well, over the last few months we've been doing a lot of stakeholder engagement, and we did have a dedicated, the CPNI leadership has been involved in a number of workshops, but actually on our request then we asked for their help to reach out to stakeholders, and there was an invitation to all community pharmacies to participate in a workshop with us, which was dedicated to them, and that was with the neighbourhood team, my team, and Girl Cassidy. And actually, to be fair to them, they came out after work up to a hotel in Antrim, and we had a very, very good evening of discussion. So yes, they've had an opportunity like everyone else, up to now. But there's going to be a lot more opportunities. We're just in the design phase at the moment, and as we move into the next phase, it'll really be starting to put meat on the bones around, who'll be involved in the neighbourhood teams and the integrated neighbourhood teams, etc. And they'll have a very important role in that as well. So.
And did any of that factor in, Cathy, see with the 3-year commissioning plan that was agreed? So is any of this neighbourhood model and neighbourhood schemes, has that been factored into the 3-year commissioning plan?
I think that the 3-year commissioning plan is going to set community pharmacy up very, very well for neighbourhood working. The neighbourhood approach that we're developing is sort of focused very much on 2 main types of activity. One is, bringing providers at a lower level in our system, who are actually providing the services for their communities together, provider alliances, and where they have an opportunity to talk about how they are working together within their own existing funded services, but how they could collaborate better to work better, because there's overlap and people aren't aware that services are available in different services. And community pharmacy, in that regard, our commissioning plan with our ambitions to expand pharmacy first, to look at vaccination services and to look at other services over the 3 years, would be very much about improving access, and meaning that for example, GPs could refer more patients directly onto community pharmacy rather than having to see them. And the second area in neighbourhood is this holding much more higher acuity patients in the community for longer. So our GPs being able to manage care for longer without referring on to hospital. And the interesting thing about that is, and in our commissioning plan we refer to it, is that we would like to see community pharmacies more involved in, for example, the treatment of long-term conditions like hypertension, etc. But we recognise that for that to be really meaningful, it has to be part of clinical pathways. And we think that the neighbourhood will be the vehicle that we've been waiting for, really, in a way, to really get that accelerated, that thinking, and really using all our assets. It isn't just community pharmacy, but they'll be critical. But it'll also be our voluntary and community sector, and our other trust-based community services more effectively, along with general practice. So I think the commissioning plan is very timely in terms of neighbourhoods.
I'm so sorry I've took up a lot of time, Chair. One quick last question. I just wanted to ask, see, with the 25 million clawback, when that money is returned to the department from community pharmacy, where does that go? If there's going to be conversations about potentially then taking that, not taking that off community pharmacy, where does that 25 million go? Right back into the central pot of money for the Department of Health? And the 2.8 million and the 1.7 million that you mentioned, Kathryn, that has been sort of retained from the clawback this year, has that been then given back to community pharmacy as additional funding?
That is part of the additional funding. That's part of the additionality. Not the 1.7, but the 2.8 is part of the additional funding, and the increase in the allocation for this year that was built into that additional funding, recognising that will stay in the community pharmacy economy. The 1.7 hasn't, so that would, in theory, that would be additional to that.
And the 25 million where that goes every year?
That is within SPPG's financial pot.
Okay, thank you. Thanks a million.
Colin?
Thank you, Chair. Thank you for the presentation. I prefer to see things in pictures because it saves having to read lots of words. And I remember seeing a picture recently that kind of enlightened me to a lot of the situations that we face. And it's a photograph, a picture, a cartoon of two people facing each other. And in between them in the ground is the number 6, if you're looking from one side, and the number 9, if you're looking from the other. And both have a speech bubble, one saying 6 and one saying 9. And it really speaks to me about this scenario of the clawback, because the sector, community pharmacy, are clearly telling us that it does not work. And yous are coming into this and yous clearly tell us that it does work. And I think we're going for about, in my time, our 3rd or 4th round of banging our head off the wall. And yous may be entirely right in saying that it works. They may be entirely right in saying that it doesn't work. But it doesn't take us away from the fact that you're saying a 9 and they're saying a 6, and this is just happening all the time. I don't know how we're going to get to the bottom of this, because we feel like we're caught in between, and we just don't know how to sort it out. And they're saying that you are taking the money out of their system, which is effectively their profit. And if the profit goes, then they as a business are finding it very difficult to be sustainable, and that they're having to face closures already and potential of future closures. And if we think of some of the other conversations that we've had about the neighbourhood model, I think is fantastic. Let's get services out into the community. But the community pharmacy are not going to be able to deliver those services if they're not there, if they have to close because they can't stay open. And they even say that if they get extra services in terms of the neighbourhood model that's coming in, that comes in sort of cost neutral. If you give them £20,000, they have to do £20,000 worth of stuff. So it doesn't help them with their overall operating costs. And if you've got a pharmacy who deals in the issue of drugs, if it's costing them money to dispense drugs, and then everything else they do is cost neutral, I don't know how they survive, because it must be on the sales of perfumes and sponges and whatever else you get whenever you go into a pharmacy. So from your perspective, I know it's difficult because, again, we're going to get the one side of it, but how would you be able to go into a process where you can look at it from their perspective to try and see where we go with this? Because any future conversations are just going to come back around to you saying the clawback works and them saying it doesn't.
I think the key thing is the evidence, and I think the margin. I think the really important thing here is the margin survey, and that's why we shared the methodology, and that's a parallel. We do that in partnership with CPNI. It's a parallel process. So they undertake and they analyse the invoices, BSO then analyse the invoices, and then it comes to an agreed position in terms of, you say, profit. And you can see from the figures we provided that profit is there, and it's exceeded the minimum threshold that we have set. So we know there is still that profit in the system, and we know that dispensing, despite not at an individual drug level maybe, but overall on average it is still profitable for community pharmacy, and it's the margin survey that tells us that is the and it's an agreed methodology, it's agreed sampling, it's all done, and say it's two parallel processes. They do their own, and a BSO do it on behalf of the health service, and then it comes together, and there are independent statisticians that work together and work out that, and that is an agreed, and that the margin that is published each year is an agreed figure between CPNI and the department. That is the figure. So those are the figures that we work off.
And then why is it maybe so difficult to do? I mean, on the 4th floor of this building there's a finance department. They're wonderful and fabulous people before I get an assessment of my finances done, but like, they literally ask us as members for a receipt for a cup of tea, a receipt for milk, or a receipt for a light bulb, or we have to vouch for every single penny that we spend, and if we don't vouch for it, we don't get it. Is it not in the modern day a possibility that a pharmacy can say through their audited accounts, this is the amount of money that I have spent on drugs, and you can accept that as a figure and go, well, we'll give you 10% on top of that because at the end of the day, they're dispensing on behalf of the health service. It's not like they're dispensing it they just want to make a few quid. They're doing it on behalf of the public sector. Is there absolutely no way that instead of the guesswork that we could actually just go on fact, here's the exact amount of money my business spent buying drugs, and you give them that plus a percentage on top, which allows them to be able to stay open? Is that too difficult a system to...
That's really what the margin survey is. That is invoices. That is actual invoices of what they have paid. And we take those invoices and we determine then against what has been reimbursed and work out the level of profit that is there.
Do they get penny for penny what they spend as a fact?
No, it is based on the margin for the... It's done from the invoices, from the margin. It's a sample, and that then is extrapolated.
I think that's where the difficulty is when we start saying sample. But is there no way to do it just factually?
Volume, but if you think of the volume, and we've talked about 45 million items a year, that's huge. And that's where it's done across the UK. All have similar kind of margin. Scotland, England, all have a similar margin approach.
But then how come in Scotland they only take back 8%? And then here we take back, is it like 20-something% here? So if it's all done the same way...
No, what I said was the margin, they all have a margin survey, they all do. They are differently approached just because they are done at different... Scotland does theirs sort of on a continual basis in Northern Ireland in agreement with CPNI, and this is something, and we constantly look at the margin survey methodology. We would like to have it absolutely in a more timely fashion, but that is the process that's been agreed at this point. So they all have it, but the actual funding arrangements, as I described, are very different between Scotland and Northern Ireland, and that's the work that we've been doing over the last... But the one thing I would say, in those discussions with Scottish Government, and we met with Scottish Government, with CPNI, with CPS, which is CPNI equivalent, and ourselves, and Scottish Government gave a presentation on their funding arrangements, and then we've had several meetings with them since. I mean, their arrangements in relation to that clawback and that approach is going to change. I mean, that's what they said. It will not. It is based on historically higher prices in their tariff that we do not have in Northern Ireland, and it will change.
I fear we're going to have to go back to the community pharmacy sector now, putting that to them and see what they say, which is...
We have shared that with...
Okay, I'm not discounting anything that you're saying. You're answering questions.
We absolutely have done, and we do. And I think the important thing is that we absolutely value the role of CPNI and the work that we do together. I mean, that's why we are able to sit here today and describe these amazing services and services that didn't exist. I mean, before COVID, we did not have... Community pharmacy didn't vaccinate anybody, and I'm able to sit here and say that as of yesterday they've vaccinated 44,000 people this winter. We've done that because of the partnership working between ourselves and CPNI, and we absolutely value those relationships and that partnership, and we'll always, whilst we won't always agree, and we will always work together to find a solution, and we'll keep working on that, and that's the promise we can give you.
And I actually would recognise that partnership working, and it's successful where it's going well. Just two final points. Number one, in terms of that sort of contract then that you agree with the pharmacist, would it be fair to typify it as a negotiation that's agreed, or would it be a contract that's imposed?
We work within a contractual framework, so it's a contractual framework, and then within that there's a funding envelope set, and then there's a commissioning plan for services, and that is the way it works in Northern Ireland.
So negotiated or imposed?
I wouldn't use I use either, really. It's a contractual framework for which the funding is determined by the department, and a commissioning plan, as we've said, the agreed commissioning plan determines the services, and then we deliver within that funding that's available to us.
Do you negotiate that with the sector, or is it that...
The commission plan, absolutely, and that's what we've talked about. We've talked about the work we've done to agree that 3-year commissioning plan for the period from now moving forward.
And then just very quickly and very finally, I think we'll revisit that one as well. Orlia had made a point there about the pensions. So GP federations are also independent providers, GP practices are independent providers, but in their contractual monies that goes to them, there is an allowance for pensions. why is that different for the community pharmacy sector? Because they also are independent providers, but they don't even get that allocation in their budget, and other parts of our health service that are independent providers also get, but they get as part of their funding arrangement, they get monies for pensions. Is that something that could be checked out or revisited, or just to check it against other, because if you're giving one part of our health service, independent providers, an allowance for pensions and then not to another, that would seem unfair.
Well, we don't provide a pension for the independent contractors in community pharmacy, and that's the case across the UK. But we're happy to come back.
It's not the case here across the board, because we give other independent providers
but
pension.
But we can come back to you with with more information about that.
Okay, thank you, Chair.
Annie?
Thank you, Chair. Similarly to Colin, I had a lot of questions in that type of area as well. Just around the funding, now it seems that there is both drug profit and overall funding is set by the department. Is that fair?
The funding is determined by the department, yes. And that's when we've increased that funding by over £50 million in the last 7 years.
So is overall funding negotiated at all with CPNI?
Certainly would, in terms of where that funding is spent, in terms of looking at the new services, and we agree the services, and yes, so there is discussion in relation to the service and what services we'll commission, and we also will be when we're looking at new services, we will be absolutely working with CPNI in terms of the remuneration rates for those services. So we will absolutely, so for the sore throat service, when we negotiated, I mean, CPNI obviously made a case for needing the pharmacist's ability to set up the service and then to be able to actually, the cost of delivering that service.
Is there ongoing negotiations with CPNI about overall funding, including the core funding?
We certainly discuss it at the commissioning oversight group, but it's in terms of what the funding that has been determined.
In terms of cost of service, when was the last cost of service review done?
2015, I think.
So 10 years ago. Do you think it has changed much since? The cost of service, the cost of delivering medicines in Northern Ireland?
I think the range of services obviously has transformed really in that period.
Okay. When was, you said you do negotiate with CPNI over funding there. When was the last negotiations about overall funding? I said that we, in terms of when we're looking at new services and different services, then we will obviously take their views in terms of the funding and the funding that we have available, and they will put a case for that service, for the funding for that service. That's what I said. Is he negotiating yes or no?
In relation to those services that yes, it is, but it's in relation to the funding we have available to us to deliver that service. So, but
overall funding for community pharmacy in Northern Ireland, do you negotiate with CPNI?
We certainly listen to CPNI's views.
Is that a negotiation?
As I've said, the arrangements are that the funding is determined by the department. And that is the contract framework is made up of the funding and then the commissioning plan to deliver those services.
They're saying very loudly to us that the funding arrangement doesn't work for them. We have heard about pharmacies that have closed. You're saying you listen to them. You're not negotiating with them in my book then, but that's for you to say. But
we have increased the funding that's been available to community pharmacy by over £50 million in the last 7 years. That's a huge increase.
Is that for additional services?
That has been for different elements of the both the core and the services.
The core funding?
That has increased, and it increases year on year. And they're aligned to DDRB, and that uplift.
In terms of what CPNI is saying, it costs them to deliver the service. What are the negotiations around that core funding between yourselves and this representative body for the group that represents medicine delivery in Northern Ireland?
We certainly have the arrangements that I've described around the commissioning oversight group, and then the different elements within that, particularly around the drug tariff and the service side. We meet regularly with them to discuss the relevant issues in each of those areas.
You don't negotiate the core funding, you set it. That's
determined by the department.
the government sets it. Can I just ask, Cathy, I think you had mentioned the number of pharmacies in Northern Ireland at the minute, and there have been a couple that have closed over the last couple of years. I've met with pharmacists who describe financial hardship, effects on their health, operating at the edge of bankruptcy. So this is a tough business for them to be in. Every time they tell me that it is about the funding arrangement makes it very hard for them to operate. We've had presentations here from a pharmacist who has pharmacies here and pharmacies in Scotland, and the pharmacies in Scotland are subsidising the pharmacy business here because they wouldn't make money otherwise. I know Colin has said about retail subsidising the medicine delivery side, and that's something I've heard time and time again as well, that their shop element is subsidising the business surviving. So how is that a stable sector, and how is the funding correct then?
I mean, as far as there's no denying the health service is under pressure in all areas. The demand from the public for services is increasing. Community pharmacy are bearing a lot of the brunt of that at the moment. And also we are encouraging people to go to their pharmacies as well. Now, in doing that, we are, all of the things that we're trying to do to help them in terms of legislative changes, workforce and additional funding.
Encourage people to do it more, and they're losing money every time they're delivering a service. They're losing more and more money.
That's why we have the assurances built in relation to the margin survey, in relation to the annual review that we do of funding, because our responsibility is around fair and reasonable funding. And we are assured that we are in that position at the moment. We don't have closures in Northern Ireland on the scale that we've seen elsewhere in the UK. We had a number of closures 2 years ago, and that was, we advised the committee at that time, we believed that was due to consolidation of a number of large companies and divesting from one a large company, and that we didn't believe it was a trend at that time affecting our pharmacies, and that's been borne out in the last 2 years. We had 3 pharmacies last year, none this year.
It's not the pharmacists that I've spoken to here saying it's very, very hard.
Closing.
Does the department believe there are too many community pharmacies in Northern Ireland?
We don't believe. We know we have more here than we have.
There's too many.
We don't believe there's too many. I mean, they're highly valued, and they are, there's, as I said, there's wide access, and that's important. Again, in neighbourhood, as we move forward, that's going to be important. In some of our rural areas, as I say, they provide really vital services in the absence of other health services. We don't have a policy position on numbers.
And I'm glad to hear it. And certainly, from my perspective, I visited a lot of pharmacies in my constituency, in rural areas as well. I know people rely on them very heavily for the delivery of medicines, and it is. It is quite a serious issue for people to think that their medicine supply might be interrupted. It panics people, and absolutely rightly so. Have wholesale or pharmacy owners conveyed any concerns to the department at any stage in the last 12 to 24 months about pharmacy owners' ability to pay their wholesaler bills?
We have had representations from pharmacy owners, yes.
And from wholesalers?
From a number of wholesalers as well, yes, which we subsequently met with.
Okay, so wholesalers are telling you they're concerned that pharmacy owners can't pay their bills. So wholesalers are telling the department that. Well, pharmacy owners are telling you that.
And we have revisited those discussions with wholesalers on a regular basis. And at a point in time, there were some actions taken by pharmacy owners. This is quite some time ago now. Maybe I can come back here with more detail on this, because I'm just giving it from my memory of this. But certainly within that time frame, there were issues highlighted to the department. We took action to speak directly to the wholesalers involved, and to understand the issues at that time. I can come back. I can provide more information about that, and also about our more recent, because we have stayed in contact with the wholesalers on this matter. Obviously, we work closely with wholesalers anyway, and in my team, between COVID and EU exit, we have trusted relationships there, but we are aware of those issues, and we do keep in contact.
There are issues with wholesalers being concerned about community pharmacists not being able to pay their bills.
Not at this time that I'm aware of, but we have had recently.
Not at this time?
Not at this time that I've been made aware of. I'll have to come back to you, Danny. I can't remember the last time, but it was some time ago.
Are you aware that if wholesalers have to have credit insurance to make sure that the risk overpayments of medicine in Northern Ireland is covered?
Comment on that, sir.
You're not aware, or
No, I can't comment on the detail of the arrangements between wholesalers and the community pharmacies. I don't know. We can confirm that if you're. Is that a question?
yes,
Is it a question if they do have it?
you're aware or not?
I'm not aware.
You're not aware of whether they have or not. Do you know if any wholesalers have left Northern Ireland in the last year?
We have lost wholesalers, smaller wholesalers, and these are business decisions that are made that are outside of our control. It was something we monitored closely around EU exit time, and again, look, it comes back to the importance of the mechanisms that we have in place around margin survey and things, so that we can continually track and provide. That SPPG can provide the department with the assurance that we need around the level of margin, because I think the implication would be that pharmacies would have to pay more if they haven't got the competition.
Well, that's what I was going to ask. Does it make it harder for pharmacies?
That is what we need to be mindful of.
Yeah.
And we are. So we do track that.
Wholesalers have approached you and said there's a problem with community pharmacists in Northern Ireland being able to pay their bills. Now, I've heard from community pharmacists that struggle to pay wholesaler bills, and I'm not going to name any of them, but I've heard from them. They find it a huge pressure. Wholesalers, my understanding is that some of them have had to have insurance arrangements in order to cover that. You've just told us that wholesalers have left Northern Ireland. So there's clearly a problem here. We're hearing from pharmacists that the problem is the clawback. There's £25 million is taken out, and it appears to subsidise other areas in the health service. So that gets taken out of this arrangement. It would appear that it is a solution as well, that the clawback is the solution. If the clawback was not taken out, then all these pressures would disappear. Previously, you have released the clawback. In the last couple of years, I think there's been a few examples where you have not taken clawback for several months. So clearly it is a lever you can pull. During those times of significant financial pressures, what was the thing that made you stop the clawback?
I think there was a concern it was done at a point in time the year before last, and there was a concern that the margin would not deliver the profit that the margin survey.
Was there a threshold?
There was yes, there is a.
What is the threshold for the clawback?
For that year, it was 31.5 million.
So
and the concern was at the point in the year that threshold would not be achieved. That was not realised. At the end, when the margin survey was, so the clawback was withheld, and then when the margin survey was complete and published, the margin was significantly over the threshold, and I think it would be in your briefing pack. So there was and that was why it was the concern that year that the threshold would not be met. But in hindsight, the threshold was exceeded.
Medicine's delivery were at risk because of that.
Well, that was the potential, but it actually turned out when the margin survey results came in and the margin was analysed, that did not, and it did not happen. The actual margin.
Because the clawback was stopped.
No. If you know, the minimum threshold was exceeded beyond the level that was taken out for the months that clawback was so it was high. So the concerns were obviously were listened to by the department, and then when the margin actually published, it turned out that actually the margin was
well exceeded.
Absolutely.
Okay, I'm confused again as well, because I'm hearing from one group of people who are saying that they're underfunded and they're financially stressed to the point where it's affecting their health trying to run this business. And you're basically saying that the margin is okay and they're having enough profit. We're also seeing a couple have closed in the last couple of years, a couple of actions that you've had to take in the last couple of years in order to keep medicine supply happening.
But we were concerned about, and we will always listen, and that's why at that time that action was taken. But obviously then it's all based on the evidence that is provided us through that agreed methodology, and everything in the margin survey is agreed between CPNI and the department. And when that came through, it turned out that thankfully, and absolutely, the last thing, I mean, you've heard all the things that we want to deliver. I mean, Cathy and I are pharmacists, we are community pharmacists by background, so we genuinely believe in the sector, and we want to ensure that we have the most vibrant community pharmacy sector in Northern Ireland.
It is a very, very important sector, and it mentioned in the Winter Preparedness Plan and all the projects that you've talked about that you hope to roll out in the next 3 years, which is fantastic to hear. Would you consider doing a cost of service review, an updated one, and then negotiate with CPNI about core funding?
I can't comment on that today. That would be for others to make a decision.
Who would have to make that decision? The Minister?
I mean, we would be advising the Minister that the evidence that we've got at the moment wouldn't indicate the need for that. I mean, and that again, it's coming back to the margin survey and the annual review and the report. I mean, this comes down to working within the funding that we've got available for the service, then carrying out evidence-based analysis that shows us we're getting the service delivered for the money that we're provided, for the money that is available to us, and that we are growing the funding each year in line with the available funding and more, and also aligning with DDRB. So at the moment we don't recognise the need for that.
You don't recognise the need for doing that cost of service review or to negotiate with CPNI?
Our funding, the funding for community pharmacy is set by the department each year, and then we work as described where possible to negotiate in terms of the most beneficial ways to use the additional money. We have placed a big emphasis on getting additional money into the sector. Okay. And that is evidenced again in the report. So we can see we are growing the money that goes in, and that is our opportunity for negotiation, is by getting extra money and negotiating there. I mean, you can see the work programme that we're involved in here, and you have to, I mean, seeking additional investigations and things like that we don't recognise are necessary, divert attention away from some of the significant progress that we are on the cusp of here in terms of the sector.
I mean, our strength has been in our working together with CPNI to deliver the services that we described, and that's what you can see. I appreciate that.
But what we've heard from pharmacists is that this is a service at risk, and if those pharmacists stop closing down, as Colin pointed out, they'll not be able to deliver all those new things that you're talking about. I would appeal to you to negotiate with CPNI about how much it costs to deliver this service, and to consider that cost of service review that is now 10 years out of date. Thank you, Chair.
Yes, I mean, at the risk of everybody raising this issue, I think there's clear frustration within this committee. I mean, we fully support community pharmacy, we recognise the need for community pharmacy. There's a clear consensus thus far, and I'm sure everybody else coming in will expect the same. So, what we want you to take away from this meeting is that there is this disagreement. As Colin has said, we're clearly hearing two sides of the story, but one side is clearly from the community pharmacies who are saying they are under pressure. Here's the reasons why we're under pressure. We want to engage with the department about resolving that issue. And I mean, I think if you were able to give us that commitment that you will go away and engage seriously, and the department will go away and engage seriously with community pharmacy on the issue of core funding and clawback, we could save at least 20 minutes of this conversation.
We have mechanisms to have those conversations. Yeah. I mean, we're meeting with them on a regular basis, so we can assure you of that. And they are being raised. Okay,
so you're giving a commitment that the next engagement with CPNA, there will be a serious conversation around the core funding and the clawback issue.
I think they are raised at each of our meetings already, Chair, but I can assure you that they will be on the agenda.
Fair enough. Well, I mean, the committee might take some decisions after the meeting too. Dan?
Thank you. So, just for my simple mind.
I didn't look at it. I took it the other way.
Just for my simple head. You are telling me that there is a profitable activity or profit margin of 31.5 million. Is that
minimum threshold?
That's the minimum threshold.
Sorry, that was last year. It's now been
and
increased
next year's going to be 34
million. 25, 26 of the year we're in.
How's that made up?
That's the profit that they make.
But
on
how
being-
is
on
it
being
made up?
able to purchase medicines and get a discount from the
So it's
wholesalers.
wholly on medicines, it's not on additional services that are commissioned?
No, this is purely on their ability
Okay.
to purchase medicines at lower than the reimbursement price that we reimburse them through the Northern Ireland drug tariff.
Okay, so this
take that
is
in
based
theory.
purely on the dispensing of medicines, just for clarity.
Yes, it is.
Buying
That's-
and selling.
Yeah.
They buy at one price.
Yeah,
And
no,
then
I
they're paid
understand
back
that,
at a
I
higher
understand
price.
that, that's fine.
Overall.
I suppose, in terms of the total funding, and that you are saying is 163.4 million for community pharmacy. I'm presuming from your conversation today, that is set by the department. And there's been a lot of talk about negotiation around this. So you have 163.4 million, and the negotiation really is on how that's divided up in terms of services.
Elements of it. Some of it is fixed.
Right.
but elements-
So there's no negotiation on the 163.4 million in the way that GPs will have a negotiation over their overall contract funding. This is set by the department, it's not negotiated with CPNI.
The way the contract framework is set up, the funding is determined by the department, and then there is a commissioning framework for which we then commission the
Divvy it out
services.
among all the different services. So there's no, I'm just to be clear, there's no negotiation. It's 163.4 million. That's what you've got. That's what you've got to decide how to
Years that we've
separate
grown
it.
that. We've grown that from a baseline of
I know,
104.
I accept
Yeah.
that. I'm not,
No.
I'm just,
Yeah.
there's been a lot of talk about, is there a negotiation, isn't there a negotiation, et cetera, et cetera. But what we know is that 163.4 million is set by the department, and the only negotiation then is what services this actually buys in terms of community pharmacy. Why, you're going to tell me it's the way it's set up, but why is it set up in that particular way, in that other independent contractors negotiate an overall amount, but community pharmacy doesn't?
The way the contract framework has been set and determined, and that's what we work within. And we work within that available funding. And we grow, and we've focused our work on growing that available funding, and that's where we have focused.
No, and
Yeah.
Kathryn, I'm not disagreeing with that. I'm just trying to work out the basics of it, because every time we come here, it's he said, she said, and we've got to get past it, because I have a sector. I mean, I have a very vibrant community pharmacy sector, who are telling me that it's very, very difficult to make it work, and yet you're saying to me that it isn't. And that there is a profit margin within this, baked into the system. And it's a bit like Collins, she said she sees 6 and he sees 9. You know, we've got to work out how that actually works out. You said in your evidence there that in 25-26 there was clawback was reduced on medical appliances. Did any of that clawback see its way back to community pharmacists?
Yes, it did. That is within the.
No. Additional to the profit margin, but it didn't individually. So, it didn't. Whatever appliances those were for, when it was reduced in 25-26, I'm presuming it's within this margin of error margin.
No, it's outside of the margin survey. The margin survey's drugs, appliances we don't take any discount off appliances at all.
But at one stage you did,
We did previously, but
but there was no refund to community pharmacists who were buying these at a loss all that time.
at that stage, I suppose it was once we had the evidence, and I say last year it was part of the funding package, and we do know that there is some, and we have seen some discount on appliances, but we made the decision to increase the funding package to stop taking discount off appliances as a whole, and that was a decision to increase the funding for the sector.
In terms of transformation funding, and this committee has also been really involved in the palliative care report, and some of our pharmacies do conform and sign up to, you know, those standards, the Daffodil standards. What do you see as the additional funding that would come with the transformation funding to community pharmacy? Sorry, excuse me.
The funding from the transformation
It's just purely for
fund
the
that we've bid
prescriptions.
for would be for the systems. So it would be 43 million pounds for the 2 big digital infrastructure projects to introduce new
Have you an
systems.
estimate of how much in terms of time, etc., that would save community pharmacy?
We have all of that worked out, and we can. I'd be happy to provide a summary to the
That
committee
would be
of that.
interesting just to
Because
see.
it was
Does-
an important part of our bid
yes.
was to show the benefits realisation. So we
okay.
do have that.
Okay, that's fine. And you also then talked in terms of the neighbourhood model of additional services and so on that would come to community pharmacy. Will you be working on additional funding to fund those services in community pharmacy?
We would like to see more investment or the use of existing money within the system, more of that moving into community pharmacy, definitely.
Because we can't expect community pharmacists who are pretty. I mean, in mine, I never see one that's not busy or, you know, always doing things. I think it's.
We have a good process for the commissioning of services, and that is a fully agreed process as well with CPNI around the fees that would be expected. So any additional services would be fully costed out.
I do think,
funded.
and I would agree with the chair, that we need to get to the bottom of why one person says this is not profitable and that this service is at risk, and you're telling us this is, and what is the crux of that figure that makes it turn either way, and all the times we've talked to either you or community pharmacy, I don't think we've ever got to the bottom of that. And I'd really like to see a resolution to it. Thank you very much.
I'm going to abuse my position before I ask Alan, because the 34 million, the profit margin, if you divide by 508 pharmacies, you know, you're in between something like 60 to 70,000 per pharmacy. So, I mean, most pharmacies could have 4 to 10 staff.
Easily.
So, like, I'm just wondering, how do they pay? You know, like, if you're a pharmacist and you go to university for 6 or 7 years.
That's just the profit on medicines. That's not.
No, I understand that, but I mean, what Colin said is also very valuable in this as well. That additional services sometimes don't come with profitability. You know, the pharmacist's main business should be dispensing medicine, so that should be the majority of their profits.
And there are dispensing fees that are built into that overall 163.4 million that pharmacists get for that dispensing process, on top of then the profit. And when we talk about the profit margin of 34 million, that's the minimum threshold. Obviously, it has exceeded.
Oh, and I understand that,
so,
but
it's not. But they within the 163.4 million, there are dispensing fees for dispensing. And pharmacists, that is part of that funding envelope of 100. So they get, I think, £1. Gosh, I'd have to get the exact figure for this year, but it is for every item that they dispense, and that is also part of their.
Well, I understand, but if you've 6 or 7 staff and your average income from dispensing is £62,000. No, I've had a local pharmacist who actually showed me his accounts. He showed me what he earned that year. You know, it's not something I would be going to university to study 6 years for to claim on a wage on a yearly basis. I'm just making that point. I think it's Dan. Everybody's making the point. We need to get to the bottom of this to ensure that a very vital, valuable service is remunerated appropriately. Alan?
Thanks, Chair. Very much in a similar vein to others. The report directs us in a direction of travel that things are relatively rosy in the garden for community pharmacy. However, community pharmacy tell us something entirely different. And indeed, I made reference to it at the previous occasion that you presented to yourselves that I've seen the books embarrassingly as it was for that pharmacist, he opened his books and he showed them. I can assure you that anybody in this room certainly would not be doing the job that he was doing for the money that he was taking home. And the report, Cathy, you had said in the report that only, if I can use that word, only 3 had closed in the 12 months previously, and you also made reference to none to date this year. And whilst that is good, but how many of those pharmacists of that 508 are citing to yourselves that they're in financial distress? Is that data carried by the department, or is CPNI carrying that data, and are they telling you that data when they're meeting with you quarterly?
Will we see any that we receive in correspondence cases?
No, we don't. We that information. We do not have. We do not have that information on.
See, I find that incredible, because I mean, if
But that's not being reported to us.
and that's the point, that they're reporting it to us.
Yeah.
But why are they not reporting it to CPNI, or why is CPNI
The
not
vehicle
reporting
is
to
through
you?
CPNI to us through, and then all of our regular engagement with CPNI is their nominated body.
Okay. Well, just then, following on from that, then, what contingencies then are in place? Say, for example, that a pharmacist does indeed say that they're in incredible financial distress and they're at the point of closure. I get it that they're independent, but are there contingencies in place? Say, for example, a rural pharmacy that will leave a huge gap in that isolated area. Is there anybody steps in? No, I assume.
We do have a rural access payment for rural pharmacies that is to support rural pharmacies, and that is paid to a number of contractors each year.
How does that work then, Cal? Explain that to me.
There are qualifying criteria for the pharmacies, and they get additional payment for being a rural pharmacy.
Okay. The other issue, just obviously given the impending multi-year budget, is the department planning a multi-year settlement for community pharmacy, or is that part of the overall 3-year plan that you're referring to?
It would be part of the bigger plan, and certainly a 3-year budget would provide certainty overall for health,
Okay.
And then allow us to make decisions around what would be available to take forward. You can see we have a lot of ambition. There's a lot of areas that we would like to see money spent in pharmacy over the next 3 years. And so securing a 3-year budget would be absolutely excellent. But it all depends on the quantum and other demands on it, which are outside of our control.
Similar to what others have been saying during their contributions here, I mean, this is something that is just rinse and repeat. I mean, my father served in this place for many years, almost 2 decades, and I can remember him 10, 12, 13 years ago going over the same ground that we're going over today. And we do hope that we do get to a point in the stage in which, when you walk through the door and CP and I walk through the door, that the two bodies walk together hand in hand, content, and saying the same thing, rather than one walking in and telling us one thing and CP and I walking in and telling us an entirely different thing. Thanks, Jan.
I can assure you we do agree on a very large number of areas, but there are some areas that we don't agree on, and this is one. So I accept that.
And I don't think anybody disputes that. I think the point we're all trying to make is we want to see those small areas, but they're important areas, discussion. So anyway, we thank you very much. That was informative.
Thank you.
As ever. Thank you.
I appreciate that.
Okay, members, I'm going to make a suggestion that we schedule CPNA for a briefing early in the new year, and also I'm also going to suggest that we write or seek agreement that we write as a committee to the Minister, just again expressing our frustration and asking the Minister to look at this issue of engaging or directing the department to engage seriously with CPNA around the issue of core funding and clawback issue. Danny.
I think that's absolutely the right thing to do. Could we make it clear that they should negotiate the funding with CPNI, because it appears that they're listening but not negotiating, which seems to be the nub of the problem.
Yeah, can I ask as well, do you think, is there, maybe take Kate's advice on this, is there any value in asking the library to do a paper for us on this clawback issue, to give us maybe some historical context, to maybe give a slightly one step back view by saying this is what it is, this is how it's constructed, this is done, and if we had that paper before community pharmacy come up to us, at least then it would give us an understanding that we could then say, how does that work out, because it does feel like we're getting a two sides, and it might equip us better if we had that, if that worked.
Does agree with that, Leah?
Yes, and I agree with everything that's been proposed, but it's just, I think every member made the same point, that we've been covering the same ground over and over again. And I mean, Alan's last point there, even from his father, you know, that this has been ongoing for a long time, and it's like we've had multiple presentations separately from department and the community pharmacy, and I don't know if it's possible or doable, but if we get that paper drafted up, and with all the experience we have as members in these conversations, if it's possible to do some form of joint meeting, briefing session with the department and with community pharmacy, because it just almost feels like you're treading water and getting nowhere doing it separately, and I'm just putting it out there as an idea.
Oh, sorry.
Yeah, just a stat I think that I would find useful if it was possible to establish this, but in their written presentation there from the department, they're saying that the yes, on occasions pharmacists are getting paid in the clawback less than what they paid for the drugs, but they're saying that on other occasions they're getting more than what they paid for the drugs. Now, that's okay if that balances out on a weekly, monthly, yearly basis, then fair enough. But it would be interesting to just to establish what are the stats, how many times, what's the percentage of drugs that the department is paying more than what the pharmacist paid for it, or less. And you know, if it's a total imbalance, then yes, it makes a good soundbite to say, well, sometimes they get more than what they're entitled to. That's a good soundbite, but you'd like to see it maybe supported by statistics.
And I don't know if that's something the research can do, or whether we need to ask the department, but I don't disagree with asking for that, either from research or the department.
Yeah.
If your indulgence to say as well, I think the difficulty is that there is a budget that is set, and then they try to get the formula after they've set the budget, and rather than actually having a formula that results in a budget. But I also want to put on record, I feel that leaves it very, very difficult for those officers from the department to come up and present, because they're only presenting with what's actually in front of them.
That's why
and you can sense their frustration as well, but we're also having to try and bring that sort of that real life outside experience to it as well. But
ultimately it's an issue for the minister.
Yeah.
So, and that's why I'm suggesting we write to the minister to express, and I'm just not 100% sure earlier on your suggestion, because we're not a decision making body, so you know, we can pull everybody together, but the department probably wouldn't engage in that. So I think what we could do in terms of us disposing our functions, if you can keep me right here, is by writing to the minister expressing our frustration that this issue hasn't been solved, and asking the minister to take all of that frustration on board and come up with a solution to solve it.
It's just on that point, Chair, because it was Cathy had says at the end there that essentially she wouldn't be recommending, they would have to make a recommendation to the minister, not have to, but that's, you know, so, and that she wouldn't be recommending that, because they don't deem that a review, it was in response to Danny, that a review or negotiation is necessary. So this is where we're back to the gridlock.
Could we add, just on top of that, could we add on to the letter that we suggest the minister should do an updated cost of services review?
Yeah, I'm happy enough. I mean, the minister is going to be here in, sorry, I was going to say January, he's not coming, it's a budget to February. You know, all of these things we can put directly to the minister or whatever.
in the 60 minutes that he's here.
Yeah. Okay, so are we content to write to the minister on the basis of that? Okay. It is very frustrating that every time this issue comes up that we're hearing this. Okay, moving on, item number 6, SL1, Amendment to Regulation and Improvement Authority. Can I refer members to papers at tab 6, page 38 of the main pack, and that includes a clerk's memo at page 39 and SL1 at page 41. And can I welcome Mr. Aaron Thompson, Principal, Quality Regulation Improvement Branch within the department, and also Miss Stefani Millar, Head of Looked After Children and Adoption Policy Unit within the department. So you're very welcome, both of you. Sorry, we're a wee bit behind schedule, and we're going to hand over to yourself just for some brief introductory remarks.
Good afternoon, Chair and members of the committee. Thank you for the opportunity to attend today's session. I am, as introduced, Aaron Thompson, Head of the Quality Regulation and Improvement Branch in the Department of Health, and I am indeed joined by Stefani Millar, Head of Look After Children and the Adoption Policy Unit. Members hopefully will have received the SL1 paper from us in advance of the session today and have had some time to consider it. We're here to provide just a wee brief overview for you on the proposed amendment to the Regulation and Improvement Authority Fees and Frequencies of Inspections Regulations Northern Ireland 2005, and to answer any questions that members might have on it. So just in summary, this amendment will set a statutory minimum frequency of inspections by the Regulatory Quality Improvement Authority, the RQIA, for fostering agencies here in Northern Ireland, and it will set this at once every 3 years. The committee previously approved, I believe in February of this year, the Foster Placement and Fostering Agencies Regulations, Northern Ireland 2025. When these regulations come into operation, they will, amongst other things, bring fostering agencies within the scope of registration, inspection and regulation by the RQIA, hence the need to specify the minimum inspection frequency, which is the purpose of the SL1 that we've brought forward to you today. Just for your information, at present there are 4 fostering agencies in Northern Ireland that would fall under this requirement, and that once registered, the RQIA will inspect these agencies against the minimum standards for fostering services in Northern Ireland. We'd be very happy to take any of your questions.
Okay, thank you. I have a few very quick ones. In terms of consultation with the sector, what was the extent of that and the outcome of it?
Well, maybe I'll pick up on that one, because the regulations that Aaron has been presenting to you today are very much complementary to the work that my team has been leading on to introduce regulation of the fostering agency sector, to bring that into line. And you'll be aware that there were actually 2 consultations on that, one in 2024, and because that was some time ago, then there was another consultation in 2022 on draft regulations to bring the fostering agencies within scope of regulation. And then there was a further consultation this year on the fostering standards to support that. So there's been a lot of consultation carried out. There's also been a working group, as I think I outlined the last time I was in front of the committee here, to develop the standards for that. And that has included foster carers themselves, as well as the representatives through Foster Network, as well as VOIPIC, who obviously representing the voices of children and young people. In terms of the most recent consultation that we carried out, and previous ones of course, but I'll speak to the most recent one in particular, we had engaged significantly with VOIPIC in advance of the consultation around engagements for making sure that the voices of children and young people, for example, were reflected in the feedback from VOIPIC on that. So, and we had engaged last October, November time, around that time, at an event that Foster Network had very kindly arranged for us. To engage directly with foster carers again and children in foster care at that time. So there's been lots of engagement. The actual 4 fostering agencies themselves were involved in the development of the standards, and it spoke very positively of that at our last session here in February as well. So I think there's been quite a lot of engagement throughout this whole process to introduce regulation, and I would hope, I think that's been viewed quite positively by the sector. Okay,
that's good to hear. In terms of RQA and resources, obviously this is an additional ask on them. Has there any refund or any additional funding going to RQA following the introduction of this?
There has been engagement with the RQIA in terms of any additionality this will create, and obviously the appropriate business case for that will be considered in light of the wider financial pressures facing the department. But more generally, we are engaging with the RQIA to consider potential changes to the fees and frequency piece. Now, obviously, that would be subject to ministerial consideration, any recommendations that would be made, and it would be subject to wide-ranging engagement.
Yeah, there's a specific business case around this issue as well, and we had previously provided RQA with some additional funding, and this was a couple of years ago when we were thinking of bringing forward the regulations originally, to provide some additional capacity for an inspector, one new inspector in the children's side. So they have already got that, and a business case is in, and I certainly have been submitting bids periodically for RQA to support Aaron's work to make sure that they're getting as much money as we can, because these services can't operate in isolation without RQA and without having those assurances around the quality of the services that we're providing to these very vulnerable children at the end of the day. So it's something that's very much in the forefront of our mind, and while we're still working on it, we are working quite strongly to try and get that resolved.
Okay, thank you, Aaron, Stefani. Nobody has indicated, so thank you very much for coming along and providing that information.
Thank you very much for having us.
Okay, members, are we content with the merits of the policy and that the statutory rule is made? We are? Okay. If everything was as straightforward as SLs and SRs. Okay, so I'm going to move now. We're going to skip a few items because with the PSNI outside, so we're going to move directly to item 9 on the agenda, which is the oral briefing on the Adult Protection Bill.
Again.
So can I invite no papers? All right.
There is, yeah.
Just don't have the tabs of our papers, but we have it in front of us here. So under item 9, we've got our papers. So it's
1, 2, 3.
1, 2, 3 from 1, 2, 3 in our pack. Okay, can I welcome ACC Davy Beck, Crime Department PSNI, BCS Zoe McKee, Head of Public Protection Branch PSNI, and also CS Gary McDonald, Justice Branch PSNI. So all three is very welcome. Busy day for you if you were at the policing board. Some of our members haven't got from there. So
spray into policing board answers then. You can
okay, appreciate you coming. Going to hand over to yourselves just for some introductory remarks, and then we're going to take questions.
Great, thank you, Chair. Members, the committee, thank you for the opportunity to provide evidence today on behalf of the Police Service of Northern Ireland. And as you say, I'm joined with Detective Chief Superintendent Zoe McKee, our Head of Public Protection Branch, and Chief Superintendent Gary McDonald, who is our Head of our Justice Department. We welcome the committee's focus on strengthening adult safeguarding, and we really appreciate the constructive engagement that has taken place to date with us. At the outset, I want to be clear that we are supportive of the intent and the direction of travel of the Adult Protection Bill. The bill represents a significant step towards placing adult protection on a statutory footing and building the protections that vulnerable adults in Northern Ireland deserve. Our position is broadly shaped, Chair, by our experiences as a key partner in safeguarding, and critically by our profound lessons from the Muckamore Abbey Hospital and Dunmurry Manor investigations. They demonstrated very clearly that adults at risk are entitled to a system that acts quickly, proportionately and transparently, and that policing clearly has a key role to play within that system. We assess that in order to operationalise the bill safely, effectively and within the principles of proportionality and human rights, several matters require some careful consideration by you and your board. Firstly, in respect to definitions and thresholds, clear, consistent definitions of, for example, adult at risk, adults in need of protection, and of terms such as harm, serious harm and psychological harm are essential. Related thresholds must be unambiguous, not only for police officers but for all safeguarding partners. Without clarity, there is a real risk of unnecessary referrals, a duplication of effort, and frontline officers being diverted into administrative activity rather than protecting the public. This in itself would be counterproductive to the best interests of vulnerable adults. Secondly, the duty to report and to cooperate. Policing already makes safeguarding referrals daily through our established pathways. We fully accept our obligations under the bill, but primacy for adult protection must remain with health and social care. Any duplication of over-reporting will compromise our ability to respond to threat, harm and risk elsewhere. That said, criminality in any form will be the subject of robust investigation. Thirdly, new powers and expectations around visits, orders and enforcement. Police involvement in visits under Clause 5 and warrants under Clause 19 must be framed as an exception, not the norm. Police should accompany social workers only when there is a clear and evidenced risk that necessitates our presence. This is not expressly outlined in the proposed bill at this stage. We are keen to avoid any perception of an intrusive or an enforcement-led safeguarding model, and we must ensure that adults are not inadvertently caused distress through unavoidable police attendance. Similarly, the introduction of assessment orders, removal orders and banning orders will require robust, reliable information sharing arrangements with the trusts, the police and indeed the courts. Fourthly, if I can touch on CCTV and surveillance, we recognise the committee's significant interest in this area and the focus of the bill on it. Lightly informed by the criminal abuses revealed at Muckamore, our experience with body-worn video and with custody CCTV demonstrates the value of recording evidence in safeguarding victims, protecting staff and ensuring transparency. But it also highlights the need for strong governance, human rights, impact assessments, clear purpose, proportionality and secure data management. If CCTV is to be mandated or regulated in care settings, the framework must match the level of intrusion. We would take this opportunity to offer the sharing of our operational guidance and rights-based learning with the department and indeed the committee, if that is of help. Fifthly, in terms of training, capacity and cost, the scale of training required, we believe, is significant. Beyond our public protection branch officers, we estimate between 3,000 and 5,000 officers and staff would require new and enhanced awareness training. There will be costs associated with systems changes, digital pathways, guidance development and internal processes. While we and policing are committed to playing our part, it is important to be realistic. New statutory duties will place new demand on a service that is already under severe resourcing and financial pressure. As we have learned from the implementation of the Domestic Abuse Act and the Protection from Stalking Act, without sufficient lead-in time, training investment and digital readiness, risk simply transfers, usually to first responders, and I think we must avoid this. As I understand, the funding requirements outlined by the department do not include the cost of policing for the proposed bill. This will require further specific resourcing, including the requirement for initial response to reported incidents, the investigative follow-up, case building, attendance at court, management of outcomes and attendance at supporting boards, review meetings and oversight requirements. All of this needs detailed costing and consideration to avoid collective failure to meet the rising expectations and the failing of vulnerable adults. Finally, on commencement and sequencing, we welcome the use of commencement orders. It is vital that the legislation does not go live on royal assent. All partners, including policing, must have sufficient time to build guidance, systems, training and information sharing arrangement so the bill can operate as intended. Fragmented or under-resourced implementation risks creating gaps, inconsistency and ultimately undermining public confidence. Equally, the experience of the Mental Capacity Act shows that partial implementation without sustained investment can impede progress for years. The bill may also have an impact on the development of our Right Care, Right Persons project. Again, we are keen to ensure that there's early consideration of such with the department. Chair and members, the PSNI is committed to safeguarding adults at risk and to working with the Health and Social Care, RQIA and the department and indeed the wider sector to ensure that this bill translates into meaningful, practical and safe improvements. We want the legislation to succeed. Our evidence today is therefore offered in the spirit of constructive partnership informed by our Section 32 obligations of the Police Act, our learning from the past experience and by a clear focus on what vulnerable people in Northern Ireland deserve. And we appreciate the committee's engagement and we welcome your questions.
Okay, thank you very much. So you mentioned definitions and we obviously heard this last week from GPs when they came in as well. So you're concerned about the definition of adult risk and level of harm. So can I ask if you could give us some real world examples of that and the impact that that would have in terms, I mean, without breaking confidentiality or identifying people?
I think it's important that there are already a range of offences that are available under current criminal law. So, and all of those will be outlined within quite clear definitions, stated cases, case law, etc., which helps inform when certain levels, parameters are set. And particularly for responding officers and frontline officers who will be our front line, so to speak, in terms of responding to these issues, the more clarity we have in those definitions, the more that can inform our response. Clearly what we want to avoid is an overuse of policing in this setting and in this regard, particularly when you go into the care settings, etc. I think the visibility of police officers and all that entails in terms of uniform, equipment, armed, etc. That's not, I think, always in the best interest of the most vulnerable people in society. So I think the more the definitions can be sort of widened out to give as clear guidance as is possible, then I think that allows for really effective and good decision making in that regard. Maybe Gary, do you add anything from a justice perspective around that?
In terms of the I suppose really in terms of the definitions and maybe the not necessarily the conflict with right care, right person, but where this is going to interface with right care, right person, would just need to be really clear around what the thresholds look like, what the guidance looks like in terms of that police deployment, because we're in the middle of doing a lot of really meaningful work with health in terms of right care, right person. We've got the multi-agency silver group where we're looking at all sorts of if you like, health demand and how that interfaces with policing around our concern for safety calls, around walkout from healthcare establishments that might come into this space. And I suppose we're in the process of agreeing memorandums of understanding, clarifying those thresholds and when the police will step in and a little bit more around where the health could potentially, kind of retain some of that responsibility. And I suppose it'd just be really clear just to ensure that this work doesn't undermine that. And that the outworkings of this bill, so for example, when a social worker is attending to enter a premises, what the threshold looks like for police attendance, and I think that could be built in around the MOUs and definitions will be clear around that as well.
And maybe pick up a couple of things just around practical examples, and I think the range. I know last week there was evidence in relation to discussion around capacity, and there's been the Scottish definition around self-harm and neglect, so I know that you're considering a lot of things. I think for policing, we are operating really well under the adult joint protocol arrangements, so there are really robust arrangements already there, and they are specific to adults at risk and in need of protection. So there's a clear definition there that policing are very much alive to and respond to as a result. With the bill, that's why we would seek a little bit more clarity around each of those and what they mean within the bill, so that there is a really clear understanding on an operational level in terms of response attendance and how the joint working works with social services. I think from the bill itself could range from a number of different examples. You could be talking, if you go, for example, the self-harm and neglect, which I don't think that's the area that you maybe want to be focusing on, but that could be the neighbour down the road who everyone knows and is concerned about, through to what we would see very often, where an adult at risk is reporting the theft maybe of their benefits on certain times or days of the week, and then when police attend, they're not willing to support a police complaint because their perpetrator is either residing with them or they're relying on them. And I think that's always a challenge in terms of engagement. So for the likes of the rebanning and the removal orders, that would be helpful, because it will give the necessary support for social services to go in there and allow a little bit of reprieve. And then if you look to the higher end of the scale, a recent example I can give you is where police attended a home of an elderly man, and he presented, said there was nothing wrong with him after neighbours were concerned. His son was present in the house. The son categorically said there's nothing to see here. and it was only through the curiosity and the investigative mindset of attending officers they felt they just did not get what they needed, so they went back on a second occasion and spoke with the victim in that case. And when he was admitted to hospital, he had acute injuries over a period of years, skeletal surveys, really significant harm caused by a family member. So that is the kind of the scale of different real world experiences that the adults are experiencing, older people are experiencing, and I think that's where the bill can lend really good support. But it's back to the original point, just being really clear around those definitions, so that when police are responding, we're clear that we're not doing something different to what is already well established in the joint protocol world, where we work really closely. But that's seen as an additional complementary and more robust bill and set of powers replacing.
Okay. Also, in terms of resources, so I mean, you've identified the extent of what training will be needed, and then additional resources. Is there planning underway for the additional workload? I mean, is that something that you are currently planning for?
Well, I suppose the short answer is yes. As you'll be aware, we have a recovery plan which recognises that as we move forward, a significant area that we need to grow is around our public protection branch, child safeguarding, adult safeguarding, and Zoe and the team have done some specific work around this bill and potential implications around that. At this stage, it's very indicative, I think it's fair to say, as the bill sort of fleshes out and we get a better understanding around where this takes us to and the potential levels, thresholds for involvement, etc. But I think it's fair to say that there's significant work still needs to be done to really understand that on the back of the progress of the bill. But we anticipate on the back of similar legislation over the last number of years that there will be significant costs, and those costs will be recurring costs over a period of time, both in terms of the training, the actual deployments, but also the tail, if you like, in terms of the investigative work, the court cases, and the management of those processes thereafter. I don't know, so if you want to expand on that any further. But
the additional, probably unseen work that goes on in the background, say for example, if you make a comparative to say domestic homicide reviews or current serious case reviews as we know them through the public protection arrangements, they all really drain resources in terms of preparing and planning for those, the multi-agency work and collaboration that goes on in the background over and above just the investigative capacity. So that's an additional demand that we would absolutely need to consider, especially if and when there is the oversight board, the transformation board as it currently is, and the interim board when it is set up.
And I think that's where the thresholds are really important, because clearly the more we become involved, then that tail of resource commitment over effectively years it can be will continue. And I want to ensure that I'm directing that detective cadre around the front end protection of people and managing the threat, harm and risk, as opposed to the administrative functions that follow in behind that. So it's perhaps more development with the department, but that works on way, and certainly Zoe is well involved in terms of those discussions with the department.
Okay. Last question for me. You mentioned the CCTV issue and the extent of the PSNI's experience with Garda. I think, without misquoting, but I think the Commissioner for Older People actually cited the example of custody suites and CCTV usage in terms of how we could deal with the consent issue. So you talked about you had guidance that you would be prepared to hand or give to ourselves and the department if useful. I think that would be useful. So I would think that you should forward it to the department or forward to us, and we can forward it to the department in terms of that as well. But I mean, have you anything over and above that you think would be useful for us with regard to the CCTV issue and obviously the consent issue that goes along with it?
Yeah, it's a really complex area. I think whilst our experience around CCTV in the custody setting is useful, I think it's useful to a point in that there is a difference in terms of use in that. In respect of the custody provision, we have taken away someone's liberty at that stage. They're under investigation, therefore, we are taking and assuming a degree of responsibility for them, their safeguarding, but also the investigative process and the integrity of that as well. So, whilst there are comparators and lessons to be learned, I think there is a differential around what is effectively utilisation of CCTV in what would be the private space of people, and particularly vulnerable people. So I think the issues around the balance of human rights, the balance around capacity, and I'm conscious that you as a committee have taken evidence around those areas. That there is significant issues to be considered in that regard. In terms of the operational side of CCTV, Guy, do you want to add anything?
Yeah, I mean, just say obviously it works really well within the custody suite. I think you're right in terms of the difference between the custody environment and what would be essentially somebody's home environment, and that would need to be addressed. But we've went through the processes of data protection impact assessments, human rights impact assessments, the engagement with relevant stakeholders. It's been embedded in our custody suites for some time. There's really robust systems and processes around how that's managed, how it's accessed, how it's used within the custody environment, and there's very clear processes around all of that, audited processes. Of course, it's used in a very proportionate way. So, for example, within certain areas of the cell, there's pixelation, and then it's not continuous audio, for example. That will only kick in at the appropriate time. So there's different ways that you can manage the proportionate use of it, whilst understanding that it is quite obviously intrusive, even though people are only with us for maybe 24, 48 hours.
I mean, obviously there is a different set of scenarios, but I think it would be useful, the information with regard to the processes. I think that would be useful. So I'm content. Danny?
Thank you, Chair. Yeah, just picking up on just what you're saying about CCTV there, it has been a big issue that has been raised quite a bit with ourselves. Just in your opinion, how important was CCTV in the cases of Muckamore in particular?
Well, it has certainly helped. CCTV has transformed a lot of our prosecutions outside of Muckamore, but certainly in the Muckamore experience it has helped. I think it can't be seen in isolation either. I don't think it's a panacea to all things around safeguarding. It has a role to play, but I think there's a wider issue around culture, around early reporting, around people being listened to and believed, and perhaps that is the cultural issue around this, and that early intervention, early reporting, early engagement, I think all can add to the weight of prosecutions, considerations, safeguarding decision making, and lessen reliance on CCTV somewhere after the fact. So I think it's part of a suite, if you like. It's something to have in the toolkit, but I don't think it's a be all and end all. From Muckamore, do you want to?
Yeah, I mean, there was 1,400, give or take, incidents identified through the CCTV in Muckamore. I think that probably the one thing I would want to reinforce is that was as a result of the CCTV cameras being there, but the staff not knowing they were there. I from my own experience professionally, if people want to abuse somebody, they're going to find a way. So I would caution in terms of over-reliance on CCTV, but certainly from an evidential perspective, it certainly supported the Muckamore inquiry when the victims in that case did not have a voice. And I know the families in the Muckamore case would be very strong advocates, and I'm sure some of you are aware of that as well, of CCTV. So it has its pros, but it has to be balanced very, very finely with the Article 8 rights in the private setting.
And sorry, the only other point is the consequences as well. I think it's not enough just to say or to mandate around CCTV and leave it at that. So there is that issue around, and we will experience this in policing more broadly. And it can be quite frustrating when you go to review CCTV, the standard, the upkeep, the maintenance, etc., are not up to purpose, and what you're left with is a suboptimal product that does not necessarily advance investigations to the level they should be able to. There's also the issue around, well, so what are you going to do with the CCTV? So is it going to be reviewed? What's the compliance look like? What's the regime around that? And the reviewing and viewing of the Muckamore CCTV was a Herculean, massive operation for policing. So I think there has to be something considered around, well, what are you going to do with the CCTV? I don't think it's sufficient just to say you must have CCTV.
I think in the case of Muckmore, you had to watch all of it.
Yeah.
Whereas in the case of if an incident is reported, then you go back and you view that specific time period. But I can't imagine how long it must have taken for people to constantly sit, and I'm sure that was quite harrowing for them to have to sit and watch that as well, because I would imagine it's the same people again and again and again. Yeah.
It absolutely was, but it was a conscious decision in that case to review every hour, every minute of CCTV, as opposed to dip sampling, which could have been an alternative option, but I think just due to the nature of that particular investigation and the victims involved, it was the right thing to do. Yeah.
Oh, absolutely, and I hope that they get all the justice they deserve. Just around the definitions, and certainly that was something that came up last week. Capacity is a term I recognise from working as a nurse in the hospital. Who assesses capacity in a situation on the street? Would a police officer be able to assess somebody's capacity to make decisions about their own safety?
No, we don't make that assessment. So again, quite rightly, that would be a medical issue. So we will deal with people as we find them, and then the consideration around capacity would be something that would have to be considered by the right professional at the right time. So that may involve assessment, but again, and it will have a bearing on when we would take statements, etc., etc. But certainly we would not be making that decision, and I would not want us to step into that ground. It's absolutely not the place for policing to be.
So a medical practitioner makes a decision whether a patient has capacity or not, and then your response would be dictated by that decision?
By that decision, yes.
Yeah, okay, no problem. Just one other thing just about the training. You mentioned the training, 3,000 to 5,000 staff would need trained. This, and you also mentioned this would be recurring. Are we talking about every year? Are we talking about...
Well, what we have found, and certainly from some of the domestic abuse legislation that has been brought in, there was a requirement for annual refresher training, in essence, around that. So again, I think we recognise that you can't just train once and take that as being, us having reached the required level. So I think with every new procedure or process, or indeed existing processes, there is a need to refresh, refine, and make sure our people are competent in that regard. So this is not just about the upfront. I think there has to be due cognizance given to the fact that this will be something that officers will be dealing with on a regular basis. So therefore we have to ensure that they have the skills and the ability to respond in an appropriate way. So yes, we would say this would have to be recurring.
Thank you. And just one last thing, just that story you told about the elderly gentleman and the neighbours, that's chilling, and that's that's a real reminder of why this is important. And I would just commend that officer and the neighbours for being so concerned to probably save that man from future harm and possibly even worse. So thank you.
Yeah.
Yes, thank you, Chair. Thank you for the presentation. So yesterday I met your colleagues in relation to the investigation into the neurology issue and Dr. Watt. And I was, in reading, I was sort of taken by the fact that you specify the need for very clear definitions within the bill, and that you also indicate perhaps that the deterrents in the bill are not appropriate or what you would want it to be. So I suppose my question really is about the importance of the definitions, the deterrents that you would like to see, and how they interact with current law in relation to assault even, or something of that nature.
Yeah, thank you. And I suppose the short answer is the more clarity we have, because you're right, there are current offences around common assault, actual bodily harm, etc. And I think we need to be clear in terms of the overlap and indeed to avoid the duplication. And there is always that issue with new laws and potentially new offences, that we have to be clear in terms of the gap that they are intending to address, so that we don't fall into that sort of position where there is actually already a similar offence that's already there. So I think that more clarity around the definition ensures that we can direct any response in respect of this bill on new offences to the right offence, if that makes sense.
Yes. No. Sorry, could I just to come in there? So, have you had interaction with the Department of Health around the bill, and have you a pathway for inputting those concerns?
Yes, and maybe so we can pick up on that, because she represents us on that.
Yeah, absolutely. So there's a transformation board at a very senior level, actually sat this morning, and it will be sitting monthly in response to a lot of the work and the momentum that's being gained over as a result of the bill and the time frame. So that is a really good, high level, robust conversations that we have at a professional level to share where the challenges would be and to work through them collectively as a board. I think you're hearing from them maybe, or you're definitely hearing from the bill team in forthcoming weeks. And then there's an interim board that sits, which is essentially the equivalent of what would be the statutory board that comes out of the bill at this minute in time. And again, that's operational practice that informs then the transformation board. So all those conversations are going on day and daily. There's additional working groups working through the different challenges for each of the areas of the bill, and PS and I are very closely aligned and docked into those conversations. So yes, we do have the opportunity to voice some of the concerns, and not necessarily concerns, just sharing views that Mr. Beck has outlined in the opening statement.
One of the concerns that people talk to us about is the delay in implementing something like legislation on adult protection in Northern Ireland. And you talk about the need for time, to implement, etc. I think people would be concerned that, I think there is a concern that we are working on a bill for which we don't have proper costings and don't know whether it'll be funded, firstly. And secondly, that the implementation of this, because it requires implementation over a number of statutory agencies, could be delayed because of funding and capacity within those statutory agencies.
Yeah, thank you. And again, I think it's a bit the balance. I think and it may help to reassure the committee that we are already dealing with adult safeguarding within existing legislation and within existing offences. This adds to this and effectively helps address some of the gaps in the current legislation. So I just want to make sure that that's reinforced, and so we may comment further in terms of the level of safeguarding referrals we have in respect of adults at this minute in time. But I think there is a reality around this that currently, if this was to be introduced tomorrow morning, we would really struggle in terms of the funding, the resource, the technical aspects, the IT fixes that are required, etc. So whilst some of that time may seem frustrating to folk from the outside, we would need clear time and that pathway to ensure that when we are effective with this legislation, that we can actually make a difference to those communities and those vulnerable people. I think the worst thing we can do collectively is to rush this in, not be in a position to deliver it operationally, and therefore, as I say, having raised expectations, we then go on to fail those people. So I think prudence is perhaps the right approach, but a lot of this depends on funding, absolutely.
Yeah, and I think the bill of itself will go through the normal processes, will be amended, will have all of the kind of issues raised that we hear about within the committee. But the crux of the matter is how do we implement what we've got? We could have the best piece of legislation in the world, but if no route to implement it, it's not worth a lot. And I think that's that's my greatest fear with the issue. Agreed. And I've had no comfort, I would have to say, from anyone really who has presented around that issue. Thank you very much. I think it's really, really important because you are crucial to this. And I suppose, one, we don't want duplication of what is already there. We want to add to your capacity to deal with these issues if they become a criminal matter, and a clear pathway for you to do that. And I think that that's the most important thing. It was my take from yesterday, and it's still my take from today. Thank you.
What I would say, just in terms of that, funding, well rehearsed. It's the. I think the bill, the Transformation Board, who are working really hard. So I'm very confident around them being very alive to a lot of the issues that you are discussing here at committee, and making lifetime changes and decisions and considerations. You're already thinking about, what regulations and statutory guidance could potentially look like, and I think the acceptance is, because of the funding challenge, there will be a phased implementation, and that just needs a collective response across all of the organisations involved as to what is being phased when and by whom, and who does it affect. And I think to your point, it might go on for a long time, but funding is the biggest barrier here.
So you're talking to sort of people who listen to funding challenges every single time
I know.
we meet here. We're all pretty hardened to that that kind of issue. But like, for example, like we have the mental health strategy, which should really give us really a world class. It's not implemented. We have a stroke strategy that is not implemented, and I suppose part of my frustration is that if we could have the best legislation in the world, if we can't implement it, either because of your capacity to implement it or the department's capacity or whatever, it's pretty demoralising. I mean, I completely agree on the need for it, but it's pretty demoralising, and I haven't found an answer to it yet. Thank you.
Just following on from Diane's point, it would be useful. I'm kind of slightly more optimistic maybe than Diane, just because it's in the run up to Christmas. But it would be useful for us, I think, if you could potentially provide, maybe before February, if it was possible, just kind of some indication of the resource implications that this would have. I think that would be useful. And you said, Davy, about it would also help fill gaps. So there might be some savings in this for you. So if that could be identified as well, I think that would be useful for us as a committee.
We have given the Transformation Board indicative costings, so we can provide it to the committee as well. But I think it possibly needs a refresh because it's maybe a little bit outdated, and the policing position has changed over the last number of years as well. So,
thank you. Colin?
Thank you, Chair. And I suppose I have to declare an interest as a member of the Policing Board, because some of the questions are going to be about resources, and part of our job there is to deal with the resources or lack of. As Diana said, we often sit here and hear from every presenter that there's a lack of money, but it's always in the afternoon after being with the Policing Board in the morning where we hear that there's not enough money to do the work there as well. So we get it from both angles. But I suppose maybe just part of the role of going through the legislation is to interrogate it and try and find the faults with it in order to perfect it. But are there parts of this that might be good? Because would this actually clarify some of the work that your officers have to do in terms of adult protection that would make it more clear cut, which means instead of having to spend time gathering evidence or trying to build up a case, actually the legislation would say there it is, A or B, and that's the case of it. And from that perspective, might it be useful? And that will feed into what maybe the Chair is saying about where some of the benefits might come from it.
Well, I think a well-defined bill with clarity as much as possibly can be given around the definitions, the parameters, the scope, and the involvement for police perspective would be very useful in terms of providing that clarity, linking into then the right care, right person debate. I think that there's a kind of crossover into that area as well. So we need to make sure that what we're doing on one hand is not sort of defeating the issues in the other hand as well. And I think for me, I suppose the overarching concern I have about this bill is, again, police being put in a position where if there's any doubt at all, we'll refer to the police. Not only that, but we will ask the police to come along. Not only that, but the police have in the proposed bill, that resort to the use of force. And that gives me a bit of a chill, quite frankly, Chair, because I don't want us to be in that position. Clearly, if there is a requirement, we will fulfil our Article 32 obligations, absolutely. But it has to be as clearly laid out as possible, with clear requirements around health and social care and the decision-making process, the threat matrix, the escalation route. Again, experience has shown us that on occasions we have had almost debates at the doorstep between social workers and police officers around, who's deciding what is done when, etc. And unfortunately, when there is that confusion around roles, responsibilities, thresholds and parameters, that has led to significant failings. So, if there was absolute clarity, I think that helps in terms of that wider position around where does policing become involved, because, as I say, use of force in these circumstances, etc., is something that I want to avoid. I don't think that's right, and we have had those positions where officers have been called to a scene and effectively told or asked to apply handcuffs to someone so that they can be taken into a care or a place of safety. And my position is clear that those officers can't be directed to use force. It's up to them to use it. And so there's all these considerations prior to avoid those discussions. I think that's where we see police officer and indeed other professionals' time wasted when there's not that clarity, and none of us, no agency can avoid that. I think the more clarity we can bring, the more scrutiny there is around the decision making prior to the point of being on a doorstep, the better in that regard.
And I think that's something that this process is starting to enlighten for us, is that concept of the definitions need to be really, I mean, you're saying it this week, the GPs were talking about stuff last week and starting to give us real life examples of where if you don't have the correct definitions or there's ambiguity, it's going to result in confusion. And I think, GPs and yourselves, aside from other organisations, are ones that are actually named on the face of the bill as actually having to do something. So I think it's really important that we get that right for you, and we don't want you to be left in a scenario where you're in between two sides and having to not exactly know what to do next. Though we might ask you for pharmacy perspectives in that one, that's a different issue. But I wanted maybe just to ask about the right person, right care, right person. So there's been a huge amount of time taken to develop that. We had the joint committee meeting on that last year. Does some of this usurp that, or does it complement it, or will it create difficulty with that? Or again, is there a need to get it right for that policy, because there's a huge amount of work gone into that?
Yeah, and I think there is a huge need to get it right, because there's some aspects of it that might sort of conflict with it, because we're in the space right now of, I suppose what we're trying to say here is we don't want policing necessarily to be baked into the response every time, because I think over the last number of years that's what's happened, particularly in the health space, and we're trying to almost step back and untangle that. It's taken, as you say, a significant amount of effort to kind of get to the place where we've got to, where essentially we've got draft MOUs in place now with the ambulance service, for example, and a lot of work through Right Care, Right Person around walkouts from healthcare facilities, where maybe previously, and just to be frank, maybe the default position was to pick up the phone to the police. Through the session last year you referred to, and through previous briefings to the policing board around the fact that it's around £4 million worth of officer hours spent dealing with those health related calls that wouldn't necessarily fall within our section 32 responsibilities. So I think there are opportunities within the bill where, in terms of criminal offences, where a crime has been alleged, we will always be there and we will absolutely take that on. But it's just being careful around making sure that we're not baked into responses that fall short of that. And I think that's where we probably need to be closely aligned with the principles and the outworkings and all the great work that's happening with health right now, and just make sure that actually complements it. So in terms of gaining entry to premises, for example, we are engaging closely with the fire service, for example, as well around this, who also have legislative provisions around facilitating entry where there's concern for for somebody's well-being and safety, and looking and say, well, where could we rebalance potentially some of that responsibility. All of that work is governed under the joint kind of multi-agency group. So there are definitely, I think, opportunities for confliction that we need to just be careful that we deconflict in the appropriate way.
Yeah, and just maybe in that paper that comes back about the CCTV, if there was something on the audio element of it, because I know just from taking both sides of conversations, people saying that if the audio is there, it actually provides the context, which may explain everything else that follows from it. But it'd be interesting, you're saying that the audio only kicks in at certain times. So if the how that works or how that's triggered or whatever was in that wee paper about it, it would maybe help us just to see, is that something that could be included within this?
Yeah, I suppose very briefly on that, in those sort of communal areas where the entrance to the custody suite, where you're booking somebody in, all of that is captured, audio and video is captured, but in the more kind of private space of the cell, if you like, where of course it is still covered by CCTV, but that's not continuously audio recorded, but it will pick up in an intercom reaction, things like that. So yeah, there's kind of trying to deal with it in a proportionate way, whenever the cell door is closed and overnight, for example.
Sure.
Oh.
Thanks, Chair. God forbid that tomorrow morning another Muckamore scandal didn't land on your laps, but I've had major concerns about how you would cope if something like that came along at the current time. And this legislation here, we don't really know how much more pressure it's going to put on you for resource. And I know the Chair has asked you to come back in February and maybe give us some sort of an understanding of what additional resource you'll need. But unless you've put a note up the chimney for Father Christmas to bring you some resources over Christmas, and it wouldn't be dependent on that. Come the introduction of this legislation, if you come back and tell us it's going to need whatever figure it is of resource, you're going to have to conjure that up from somewhere. Would it involve taking resources from other duties? Would other duties that you're performing now suffer because you're going to have to relocate manpower, womanpower to resource it?
Yeah, thank you. I suppose where we find ourselves at the minute, so we are having to, because of the kind of cut in resources right across the organisation, we are having to dynamically respond almost by an incident to incident basis. And when I say incident, it's a major incident. So whilst a number of years ago, if we had a murder tonight, there would be a major investigation team available to respond to that murder, and they would deal with it. Because of the reality of our resourcing, I'm having to pull detectives from a number of teams to effectively form a team to deal with a murder investigation. So we have had to respond much more dynamically to need, and that's right across my own department and crime department, where I am moving detectives on a regular basis to respond to specific investigations and incidents. So yes, if we had a Muckamore Abbey incident or investigation tomorrow morning, again, I would have to take officers off maybe proactive investigations, serious and organised crime
I know you would step up to the mark,
etc. So we would do that. But to be honest, when I have done that of recent weeks, it becomes much harder, because people get to the point where they are really burnt out, and that's the position we find ourselves in now from a policing perspective, that you can only ask so much of those people, and you can only ask them so many times to surge into this area and into that area, because when they go back, their kind of core work is still there that they have to catch up on and develop and keep moving as well. So it's not a panacea. We do have a recovery plan, and we're making some progress around that. From the detective cadre, again, that takes time to pull through. So as those recruits come into the service, then they will start in uniform policing, and then over time move through into other branches and departments if they so desire. So it takes a period of time to sort of draw that through. So we're realistic in crime department, in that whilst we have had some small sort of developments around starting to draw down as a result of the recruitment, that's going to take us a number of years to grow back to where we need to go. But we do appreciate that this is not about putting people back to where they were 2-3 years ago. We have that opportunity now to, I suppose, reshape the organisation to address the demands, and one of those key areas is public protection, and in areas such as adult and children safeguarding, as I've already mentioned. So we know that's where we need more people. So we will move, as we get more detectives and we get more people into the organisation, we will move people towards those specialities, so to speak, because that's where a lot of our demand now sits. But our ability to respond is being hampered by the reality around our response. I'm not sure if that answers your question.
No, it does. Thank you.
That's kind of where we find ourselves at the moment.
Thank you.
May I just add a wee comment on that, if you don't mind? I think resourcing is fundamental to success of the bill, but it's also not a reason, because the bill is really important and it's there for a reason. It's there for a very good reason, and it's culminating, bringing together and filling potential gaps that have been there, particularly some of the lessons that we learned from Dunmurry Manor. So we really welcome it as well. But the caution here today is just around the organisational impact. But I can see it being really useful for health and social care. Our core colleagues who are also frontline, have their own daily challenges and will probably share something similar. Just to give you maybe just a bit of a context, we're already dealing with about 1,300 adult safeguarding referrals on an annual basis. So we're dealing with that in the resource that we have. In terms of demand that the additional offence types for this bill will create, we don't know what we don't know, I suppose. But if we had another Muckamore or we had another Dunmurry Manor, the likes of the offence types that have been introduced or proposed for introduction in the bill around the care providers and the care workers themselves, that will be really helpful to us from a policing perspective, because it was a gap that we saw, from Dunmurry Manor. So I just wanted to add that in as well.
And I'm glad you did, because I was going to bring it in at the end. So from a policing perspective, I'm glad that you did do this. I mean, MLAs in this assembly gets a raw deal sometimes in terms of the work that we do. This is important work. It's important legislation. It will protect vulnerable people, but these sessions are vital for us to ensure that we get it right. And we're hearing over the last couple of weeks, it isn't just as straightforward as we might have thought 3 weeks ago, and it is important that we get it right. So we appreciate you coming. So I'm not finished yet.
Just a very quick question, Chair. Picking up, Zoe, on the comment you said earlier about the Transformation Board, which you said met today.
Yes.
Well, given that you've got a seat at the table on the Transformation Board, does that automatically mean that you will have a formal seat at the table whenever that Adult Protection Board is in place? And if not, why not? Because I would have thought you would have been a key partner in that.
I would say absolutely. I would say it's a given as a statutory organisation for policing. It's something similar to the seat at the table that we have as part of the Safeguarding Board for Northern Ireland, specific to children. This is just a version for adults at risk. So yes is the answer. Yeah.
Thank you, all of you.
Thank you.
That's been very good. Appreciate that. Okay, members.
Chairman, just for the record, I should have declared I'm a member of the Policing Board as well.
I was looking around to see who else was.
We left two behind us earlier. I'm sure they're still going, are they?
Still going.
Yeah, I can imagine.
Thank you.
Okay, fair enough. And both those are on the record. So, correspondence, item number 10. Can I refer members to the correspondence list at tab 10.1 of the main pack? It's page 141, and also to correspondence from page 143. And I can just also in the table pack, we'll do the two of them together. So, table pack, there is correspondence at tab 10.24, page 61 from Caleb's Cause, NI. So, I'm going to suggest that we forward that to the department for a response. There's a number of questions in there, if everybody's happy. Okay, then in terms of both the correspondence lists in pack and table pack, everybody happy with the direction of travel and the suggested actions? Okay, thank you. Forward work programmes, can I ask members to if they have any comments in terms of the forward work programme? It's at page 200 of our pack. Everybody content with that?
Sorry, Chair. Are we going
to go back to that? Yep. Item number 12, any other business? No other business. Written briefing. That was the last one. So, no, I was going to go back to it anyway. So, in terms of written briefing, item number 7. So, we have a written briefing from Stroke Action Plan. Dan referred to it earlier on. So, it's in page 105 of the main pack. I know I have a number of points. I was just going to ask that we maybe go back and ask clarity on. One is the thrombectomy 24/7. I presume everybody's going to ask the same. So it's a commitment that keeps slipping. Can we just get some clarity on that? And then in terms of the implementation priorities 1 to 4 in the Stroke Action Plan, saying require 10 million to move to further stages. I'm just wondering if we can write and ask the department if they could quantify any long-term savings that they would have within their budget from that investment. I think that would be useful information as well. Danny?
Yeah, I was going to highlight the thrombectomy priority there as well. I was at an event recently. I suggested that expanding the thrombectomy to 24/7 would cost £5 million, but the saving of £47,000 for every patient treated means that this could be £14 million a year. Of a saving. So for a £5 million investment, you could have a £14 million return, which I think is from an investor-save point of view is huge. But the amount of suffering that this would save patients from disability and potentially save lives as well. So very, very keen to see that progressed.
Yeah.
No, I was reading the stuff around the stroke, and it is really disappointing that, like years after it's introduced, we still are not implementing the plan. And I wonder, is it worthwhile? I know it's important to write and that might form a basis for it. And Keith is going to go, what are you talking about any minute now? But I do think it would be useful to have those responsible for the implementation of that plan to actually come before the committee and talk to us about it. Because we can't have a mental health strategy that we can't implement, a stroke strategy that we can't implement, and throw up our hands and say all the time, it's the funding. Some of these issues, like the thrombectomy, would actually save us money, and we simply don't do it. And I'm at a loss with that. And I just think maybe we need the pressure of actually being able to ask somebody questions.
Well, I think that's a good enough suggestion. And I do, before Alan jumps on and defends as minister, we're all aware of the pressures within
long before as minister.
Within the health part, but we're now at the point where we have a 3-year budget, and I think that should allow all ministers, but in our case the health minister, to do some of the stuff that everybody has identified that will save money, because otherwise we're just going to keep throwing more and more money. So we do need to invest where we can save, but also produce better patient outcomes. Colin?
Chair, notwithstanding, unless you've received an internal party briefing that we have a 3-year budget, that would be an interesting nugget, because I think that's not been agreed to next week if it is. But
no, I'm just saying.
But no, I jest. I think we all know it's on its way. Hopefully, it just gets a Christmas present for next week. But I think maybe if we were getting a presentation, I fear that we can end up a little bit like the community pharmacy, where they come up and say, look, this is all we've got and this is all we can do, unless maybe we can make the slant about them highlighting exactly where the savings would come from implementing it, because then I think that gives us a really clear argument, even to go constructively to the minister to say, have you gone to the transformation fund, get the £10 million up front, implement the service, start saving £14 million a year, and then it actually will help your budget going on. But I think if we just get a briefing from them, if it just tells us how good that, it's something to say, tell us where this will actually provide savings, and then that's the argument that we go then to the minister and say, fund this.
I think it's also important. I was over in the stroke ward in Craigavon recently, just on a visit, and like the consultant there was saying, like the thrombectomy service, he says it's like a little piece of magic. You send very, very ill patients to the Royal. This procedure is carried out and they come back so much better, and their outcome will be so much better. So there'll be a very long-term saving in that long-term disability issue as well. I just think, anyway, I think it'd be good to pose some of those questions directly.
the minute access to that treatment depends on the time of day that
Yes,
you
it
have your
does.
stroke.
That's right,
Which is
yeah.
crazy.
There's, I mean, it's even, we're going to have a bigger conversation now, but I mean, there are also so many preventative measures that individuals need to, you know, like stroke is a very prevalent condition, but, you know, sometimes individuals, so there's maybe a public health messaging that is, you know, a small amount of investment in that will actually stop people suffering strokes as well. So I think a presentation on the proviso they're coming, and we want to be very helpful to them in terms of
but the
solving
detail
problems.
where the savings would come from the implementation of the strategy, and then our argument is about this will save money as well as having better outcomes for people, rather than just telling us how good the strategy is and then go, but we've no money to implement it because we're no.
That's where we've been for too many of
for
them.
10 years now.
Okay, so we'll take that on board then. Okay, so before I'm going to go into closed session just for the our strategic thingies, but before I do that, I just want to wish everybody in public forum, anybody watching this, a happy Nulla Conna, happy Christmas, and happy New Year. This is our last meeting, and as I say, our date, time, and place of our next meeting is the Thursday, the 15th of January at 2 p.m. That's our next formal committee meeting. Our next informal meeting is on Thursday, the 8th of January. That's from 10 a.m. to 3 p.m. in the Senate chamber. So we're now going to get